Hi, I'm Dr. Jared Gardner, and I'm here today with my awesome residents and fellows, and we're going to talk about granulomatous diseases and go through some cases. What is a granuloma? Just briefly, a granuloma is a collection or aggregate of histiocytes, aka macrophages, clumped together, and they are seen in a wide variety of diseases, and sometimes because of foreign material or material from our body that's in the wrong place, deposited where it's not supposed to be, sometimes because of infection, sometimes for idiopathic reasons. Some granulomas have necrosis, or some people say caseation for that, but sometimes you have necrosis, sometimes you don't. And in dermpath, we kind of use the term a little bit loosely compared to the rest of pathology, because we say things are granulomatous sometimes when we just mean that they are rich in histiocytes. So sometimes things that we would call granulomatous in dermatopathology, because they have an abundance of histiocytes, the rest of pathology might be like, where's the granuloma there? I don't see it. So just know that there are some things like that where we use the word granulomatous kind of very loosely, I think, in dermatopathology. So with that said, let's do some cases. Case 1, who wants to take it?
I can take this one, Dr. Gardner.
Okay.
This one is one of my favorites. I think even from here I can tell there's like this weird, like cloudy, like kind of spiky stuff in the dermis there. And I think this is good for gout.
Yeah, very good. Gout is, even without seeing the actual crystals, gout has a very recognizable pattern, right? Like you said, I think of these as big, puffy, pink, or sometimes they look blue. It depends. This is an old faded slide, but also it just depends a little bit on the staining, the H&E staining. Sometimes these aggregates where the gout crystals used to be are pink. Sometimes they're kind of blue or bluish pink. And then, but they like remind me of clouds. They look like kind of fluffy. And then when you go closer, you often can see kind of the outlines, the little, like you said, spiky, long needle-shaped spaces where the crystals used to be, and then they dissolve away. People have always said it's during the formalin fixation, but that seems to not actually be true. It's probably something more to do with the H&E stain itself, and also maybe to a degree the processing, the tissue processing in the laboratory. But in any case, if we polarized this is a digital slide, so we can't do that. But if we did, there'd be no crystals here. The crystals are gone, they dissolved. Sometimes if you cut an unstained slide and melt the paraffin wax off of it and don't do anything to it, don't stain it or cover slip it, sometimes you can see residual crystals. Sometimes little chunks of crystals will get left behind and not dissolve. Usually they'll look like kind of a brownish area on the slide instead of this pink stuff. Somebody asked me once, what is the pink stuff that's here? It's not crystals. What is it? Is it collagen? Is it fibrin? I don't actually know. I suspect maybe it's like fibrin, but I've actually never tried to do, like a trichrome or anything here to figure it out. In any case, the area where the crystals used to be is surrounded by giant cell reaction and histiocytes, granuloma, right? So I did forget earlier when I said granuloma is an aggregate of histiocytes. That also includes giant cells. Multinucleated giant cells are histiocyte origin. There are other types that are non-histiocytic, like tumor giant cells, but many of the types of giant cells, like foreign body giant cells, the types we see in granuloma, are usually they're histiocyte origin. Okay, so in any case, let me show you something kind of fun. What's this little structure here? The giant cell, and it's got this spiky little pink thing in the middle of a little vacuole. There's another kind of one here. It's a little bit blurry. That's an asteroid body. And isn't that a buzzword for sarcoidosis? Yes, it is, but I don't think I've ever actually seen one in real sarcoidosis. The most common place I see them is in foreign body giant cells, for whatever reason, gout or any foreign body granuloma. So they're pretty and interesting, and on a test they answer sarcoidosis. In real life, I usually see them in foreign body giant cells. Here's another one. See right there? There's another one there. It's not the prettiest because it's a little bit out of focus. So anyway, this is gout, all right? Gout, it produces the monosodium urate crystals produce a really intense granulomatous reaction, and this is very painful. And if you teach whoever is grossing the specimen, if they cut open a specimen, even if it was received in formalin and it looks chalky and chunky like it might be gout, or if the surgeon submitting it said rule out gout, if you take a glass slide and you touch it or smear it against the chalky stuff in the tissue, just fresh on the slide, and air dry it, don't do anything else to it, air dry it, Then you can look at that under the microscope with polarized light and see if there's birefringent crystals there. So that's a really great way to get a beautiful slide of gout and see the polarizable crystals, which are the birefringent crystals. But even without that, we can tell this is tell this is gout. Okay. Next case. Case 2.
I can take this one, Dr.
Okay.
Gardner. So we see deeper in the dermis structure, and when we look closely, we see multiple filamentous structures in there with granulomatous reaction around it, a few giant cells. And this is good for suture granuloma.
Very good. Yeah, and so there's lots of different types of suture. Some is dissolvable and we don't see very often, and some is more permanent. You guys know way more about suture than I do, but this is a braided synthetic suture, and if you were to use polarized light to look at this, usually this will be very birefringent and brightly polarizable, and sometimes has kind of a rainbow appearance. Let me see. I think I've actually got an example. So here's an example of when you get a really nice braided polarizable braided suture and you polarize it. Isn't that amazing? There's the so this is basically very similar to the type of suture I think that we have in the current case, because that's what it looks like on H&E. And then when you use polarized light, isn't that awesome? Pretty cool stuff. Always a nice one to show to the junior trainees, and they give appropriate oohs and ahs when you do that. So, all right, so that's a suture granuloma. And sometimes sutures can perforate out. If they're close to the top, they can perforate out through the epidermis. And another clue for a suture here is, look, we got a scar right there. All right. Case 3. Any takers?
I'll take this one.
All right.
So for this power, I noticed the kind of like bright pink, like histiocytic look, and it has a little bit of an annular appearance, which I like because it correlates with the clinical findings as well. And it kind of looks like those more eosinophilic cells are kind of crawling through the collagen there, and this one has a really good like annular appearance.
Yeah.
There, so that looks good for GA.
Yeah, very good. So we've got from low power, there are cells trickling in between or crawling between. I like that wording. That's really nice. Crawling between the reticular dermal collagen bundles, okay? And when we see any sort of cellular infiltrate in the dermis from low power that looks kind of gray or pink or pale, always think, could it be histiocytes? Then you can also think, could it be other things? Like, for example, metastatic lobular breast cancer. When it's in the skin, it can look pretty similar to granuloma annulare. I've actually seen a case that was both clinically and microscopically mimicked GA. So this case, they are histiocytes. The histiocytes crawling and trickling between the collagen. And then what you want to see, like you said, is kind of a vague palisading, or kind of a lining up like a little picket fence, if you have a really good imagination, kind of palisading of histiocytes around a central area of quote unquote necrobiosis, which basically means like degenerated collagen. And often there's going to be myxoid change or mucin in there. We can't really see that well on this slide, but usually there's a little bit of bluish mucin and the collagen looks kind of smudgy and degenerated. Sometimes it's really extensive and sometimes it's very subtle. This case, I think the degeneration is kind of subtle. But the histiocytes are kind of wrapping around, and it makes kind of a vague ring shape or annular shape. Like you said, I like that too, and I find that very satisfying. That granuloma annulare is called that because clinically it looks annular or ring-like, but microscopically, probably just out of coincidence, you also see these little rings of histiocytes wrapping around degenerated areas of collagen and mucin. It's pretty common to have inflammation in the background with granuloma annulare, including perivascular lymphs, and also eosinophils are often seen. So that's a pretty common finding to see scattered eos around there. And the trickling between collagen looks a lot like the collagen entrapment that you'd see at the periphery of a dermatofibroma. So even though we don't usually think of like granuloma annulare and dermatofibroma as being in the same differential, because clinically they look very different, you know, and it'd be hard to get those confused, I think. But microscopically, I think if you get a cut from the edge of a dermatofibroma and a cut from the edge of a granuloma annulare, they look quite similar. They're plump, histiocytic looking cells with trapping of collagen. And I would also add in a hypopigmented blue nevus into that differential, because it also has, usually the cells are a little thinner and not as plump, but they do the same collagen trapping at the edge. So those are three things that are really kind of different categories of entity, but they can have areas that mimic one another. And, you know, up close, the cells are very bland, so I do like to always look, though, and just think in my mind, is there any chance this could be carcinoma or something else? If so, add a keratin stain. That's a great way to help sort that out. All right, and there are other types of granulomatous disease that can look similar to granuloma annulare, like granulomatous drug reaction, and interstitial granulomatous dermatitis, which is kind of a granulomatous reaction pattern related to a variety of systemic processes. If you had neutrophils plus this pattern, you could think of palisaded neutrophilic and granulomatous dermatitis, which is PNGD, probably kind of closely related to interstitial granulomatous dermatitis. Those are a kind of expanded differential to think about, and you can go do some reading on those if you want to learn more about it. But basically, those are things that if you think it looks kind of like GA, but something's funny about it, either clinically or microscopically, those are some other entities that could look like this. In my experience, infection almost never produces the GA-like pattern of granulomas. So when I see this, I'm not really worrying about infection in this setting. One other thing I thought of when I first looked at this slide was actually like a xanthoma or xanthelasma, because the cells are a little bit more frothy and foamy in this particular case than usual, but the mucin and the palisading would argue against that. But when I first looked at these slides going through it, I was like, oh, it looks like a xanthoma at first glance. So, and then here's another area. And so there's something called interstitial granuloma annulare, which basically is just granuloma annulare where you don't get the good palisading, you just get the trickling histiocytes between collagen. I'm not totally sure if I believe that interstitial granuloma annulare is actually a separate thing. I kind of suspect that most cases are really just granuloma annulare where you're not sectioning into the middle of one of the palisades. You're just getting kind of the edge of it. So I don't know, maybe somebody out there disagrees with me, but I feel like I've not seen that many cases, and the ones that I had looked kind of like that, and then I cut a little more and I found the kind of palisaded ring-like areas. So anyway, take that for what you will. Case 4.
I can take this one.
All right.
So deep in the dermis, from this part, can see a decent amount of inflammation. Maybe some red blood cells as well.
Okay.
As we go closer, can see the outline of maybe some keratin flakes. But I think of this as a ruptured cyst.
Very good. Yeah, so we've got granuloma here with neutrophils, lymphocytes, probably going to be EOs, plasma cells, everything, right? All the inflammation. And the key is, why is the granuloma there? That's basically, whenever we see granulomas, that's what we want to figure out. Is there a reason for the granuloma to be here? Infectious organism, foreign debris, or debris like keratin, which our body makes keratin, but it's not supposed to be in the dermis, right? It's supposed to be inside of a hair follicle in the form of a hair shaft or on the surface of the skin. So when it gets into past the basement membrane and into the dermis, for whatever reason, the body does not like it, and it really gets overreactive. So that's why if you rupture a hair follicle or if you rupture a cyst, you get a really intense granulomatous and inflammatory response. And so the key here is finding the little thin flakes or wisps of pink keratin inside the histiocytes. Tells you that we have evidence for why this granuloma happened. Now, could there also be infection? Sure. You know, so always keep that in mind. You can have infection that produces cystic epidermal change and then rupture, so you can have that. But in this case, this looks great for a ruptured cyst. If I see a bunch of granuloma and granulation tissue that looks like it could be a ruptured cyst, but I can't find any keratin or any cyst wall, then sometimes I'll say it's granulomatous. I'll just describe it and say that this could be the sequela, I like that word, the sequela of a ruptured cyst, but I don't see keratin or a cyst wall. And that way, to at least have the treating physician keep in mind that, you know, infection's possible, other things are possible. So basically, if it doesn't get better after surgery, you know, think about rebiopsying and culturing. I had a case like that actually, where it looked very much like a ruptured cyst, but there was no keratin. And we said, probably it's just a ruptured cyst, but then it recurred right by the excision site. And on recurrence, it had more neutrophils, more granuloma. And the distribution was kind of weird, and there were AFB organisms, acid-fast bacilli, and it was actually mycobacterial infection. But in this case, this is just a ruptured cyst, and this pattern is called a keratin granuloma. Good job. Case 5.
I can take this one, Dr.
Okay.
Gardner. At low power, we look to have what may be an excision specimen.
Yep.
And the action is in the top of the dermis here. We have this sort of vague, slightly purplish, almost mucinous ring around what is probably a healing biopsy site.
Yeah.
And as we go higher in, we can see this sort of punctate material inside presumptive histiocytes, which, given the history, I would think this is good for an aluminum chloride reaction.
Yes, very good. Aluminum chloride, which is used for topical or for hemostasis after a biopsy. It's also known as Drysol. You can dab that on after you take the shave biopsy, and it stops the bleeding. Okay, and for some reason, the histiocytes like to eat it up, and when they do, they get this kind of purplish, grayish blue, like you said, punctate, granular material. That's the aluminum chloride that the histiocytes are consuming. So this is one of those things where it's histiocytic, but not usually like a proper, well-formed granuloma, just the histiocytes in the middle of this young biopsy scar. And some people have said that you know, if you're having a bad day, Dr. Rapini likes to say that he's like, well, if you're having a bad day, you could get something confused with something else. That's kind of a way he says things that I always thought was funny. So yeah, if you're having a bad day, you could get this confused with intracytoplasmic parasitization of histiocytes by infectious organisms, like a little bit similar to the pattern you'd see in leishmania or in histoplasmosis. Now, I think, like, once you know that what this is, you would probably not get it confused. But I have seen some cases that, yeah, they did look kind of similar. And the other thing is that this stuff, the aluminum chloride, will stain brightly on PAS stain. I don't think it stains on GMS. I don't know if I've ever actually tried that. But PAS will stain it, actually. The other thing you sometimes see, but not always, is you can see these purple kind of burned, calcified collagen fibers usually at the border of the scar, like right between the biopsy scar and the normal dermis. And I don't know why this doesn't always happen. So sometimes you see really robust aluminum chloride changes with really, you know, burned, calcified collagen fibers, and sometimes you see very minimal. So I don't know if it has to do with how much aluminum chloride is used or some other factor, like the patient's own, you know, immune response to it. I'm not sure what it is, but in any case, sometimes you see a lot and sometimes not very much. So in any case, it's good to know. The other reason it's good to know is so that if you're a beginner, you don't want to get this confused with leash or histo. But once you've been doing dermpath just a little bit of time, you'll see this. We see this daily. So you get really familiar with it. But the other reason it's important is because sometimes it's not clear that a person had a biopsy before. Maybe the biopsy scar is a little older and it's getting well healed. And sometimes people's scar heals really well and you can barely tell where the biopsy was. Sometimes clinically, I've seen times where a patient had a biopsy, they came back for an excision of their skin cancer, and it was really difficult to tell where the biopsy scar was. This is another plug for why we should take clinical photos before we do biopsies, because not only is it helpful if you get something rare or weird, but sometimes being able to identify the exact biopsy site is really helpful if you have a photo. So I've seen that happen where someone came back, there was no photo taken, this was many years ago, and it was a melanoma, and they couldn't find the biopsy site. So the reason I'm bringing this up is that if you have an excision and you see aluminum chloride, that tells you almost certainly a biopsy was done there, right? And someone put aluminum chloride on it. So that's a good thing to do, is to be able to find those little histiocytes. Tells you, yes, you are dealing with the biopsy site. All right. And incidentally, this is the same stuff that's in antiperspirant, aluminum chloride. So in the biopsies from the axilla, sometimes you'll see granular stuff like this trapped in the stratum corneum, and that's antiperspirant that the person had applied to their skin. So, and you can see it also in the lumens of sweat ducts near the surface also, which is part of how, I guess, aluminum chloride works at diminishing perspiration. So, But in this case, this is at a biopsy site and a good example. And then there's also some pseudoepitheliomatous reactive epidermal hyperplasia, which we see at biopsy sites sometimes. Case 6.
Sounds good. So from this power, we can see some PEH, pseudoepitheliomatous hyperplasia.
Very good.
Down, and then some inflammation below it.
Yes.
Be a hair follicle there.
Mm-hmm.
And some giant cells.
Mm-hmm.
We'll start to see some giant cells. Maybe a lot of lymphocytes.
Yep.
Then as we go closer, we can see EOs. And I wouldn't, jump to thinking that this is, pus necessarily. Yet, for some reason, I have a hard time making out the neutrophils in this one, but...
This one doesn't have a ton of neutrophils. It might have a few, but really it's more lymphocytes and histiocytes. So I agree. Normally we say this pattern is PEH plus pus, so pseudoepitheliomatous hyperplasia, this reactive epidermal change that can look almost like carcinoma, plus neutrophils. But in this case, the neutrophils are really not very many, so that's okay. But the diagnosis is still what?
There we have our Coccidioidomycosis.
Yeah, very good. So this pattern, when we see either PEH plus neutrophils plus pus, or PEH with granulomas, we always right away want to think of infection, right? And there are other things in the differential too. But this pattern is particularly common in a variety of different infections, particularly deep fungal infections in the skin. And some fungi produce this pattern. This is Coccidioidomycosis from Coccidioides infection. Other types of fungus like blastomycosis can produce this pattern as well, and pheohyphomycosis, chromoblastomycosis. Some fungus does not usually produce this pattern. Cryptococcus, when it involves the skin, does not generally create an epidermal hyperplasia like this for some reason. So let's look at the other pieces, see if there were more neutrophils over here. No, not really. But seeing the granulomas, and there's some necrosis with the granulomas, and there's inflammation with the granulomas, lymphocytes, plasma cells. I find that neutrophils plus granulomas, infection till proven otherwise. Although we saw in that case of ruptured cyst, there were neutrophils there, but that wasn't infection. But still, if I see granulomas with neutrophils, right away I'm thinking of infection. Also, if I see a lot of plasma cells around granulomas, that's kind of a soft clue for infectious etiology. So these kind of cases, you hunt around. You can look on H&E because sometimes even without a fungal stain, you can find the organisms. Otherwise, we would do a fungal stain and probably also an acid-fast bacillus stain like the phyte stain. So in this case, the organisms are here. This round empty cyst, this is the cyst of Coccidioides, and inside the cyst are lots of little endospore organisms, like little tiny dots. They almost never look like little tiny dots on the microscope that I have, at least. They usually look kind of like this slightly grainy, mushy, bluish purple stuff. And so sometimes the little endospores are still inside the cyst, and sometimes the cyst is empty, like this. So the key to recognizing, how do you know that's actually like a fungal organism? Well, you can do a fungal stain like GMS or PAS, but also see the double layer wall, and under a light microscope, an actual microscope, not digital, if you flip the condenser, you can see the refractile nature of the wall. It's kind of like thick, and so it looks a little bit 3D when you flip the condenser. That's what refractile means. At least that's my simple way to explain it. Here's another one there. So the organisms may be very sparse. So you got to hunt around. They often are in the middle of the granuloma, in the middle of the giant cells. Look at that giant cell. It is truly giant. That's huge. And then sometimes it can actually get trapped up into the pseudoepitheliomatous hyperplasia and even like perforate out of the epidermis and be present in the stratum corneum. So here's one in the middle of like one of these kind of cystic invaginations of the epidermis. And sometimes you'll like find it up here. I don't think in this case. But so there's like, 4 or 5 organisms there. You have to hunt around a little bit sometimes to find it. And that's why also if we don't find infectious organisms, but we see a pattern that looks really worrisome for infection, I'll say I did special stains, but I didn't find organisms, but I will tell the dermatologist, I still think this is concerning for infection, and I'd recommend you do a repeat biopsy for cultures if the lesion comes back or if there's still residual lesion left. So it's important to recognize that special stains are great, and even better when we can find the organisms on H&E. But sometimes if we don't find organisms, but the pattern still looks worrisome for infection, cultures are the important thing to do, because cultures can sometimes identify organisms even when none are seen on special stains. But in this case, no special stain was even needed. The organisms are right there. So Coccidioides, something that I basically never see in my practice because I've never practiced in the American Southwest. These are from the areas like in Arizona or in the San Joaquin Valley area in California. And they're soil-dwelling fungus that can infect the lungs or the skin or other parts of the body. All right. Coccidioides.
Obviously, we're in the granulomatous chapter, but it looks granulomatous. There's a ton of like necrosis. It's everywhere. It's a pretty deep process to be sure once we get in, we're going to see lots of giant cells.
Yes.
Yep, tons of them. I'm trying to hallucinate to see these cholesterol clefts. I'll be honest. Dr. Gardner, I don't know if that's...
Well, there are some cracks in here, but I'm not 100% sure if these are really cholesterol crystals or just clefts between the collagen. But I thought I did see some. Probably some of these are cholesterol crystals, but I don't know.
I believe you.
No, don't believe me too much. I'm not totally convinced myself. But in any case, I think the pattern overall, even without cholesterol, which you don't always have, but even without free lipid, the pattern here is pretty good for what?
So sorry, my volume's cutting out, so I'm trying to listen on Terrace computer too, but this looks like NXG, this pattern.
Yeah.
How big it is.
Good. So this pattern, I would say, is kind of, it falls into the necrobiotic, palisaded necrobiotic granuloma pattern, right? Where you kind of have zones of necrosis / it looks kind of like necrosis, but when we go closer, it's really like dead and degenerated collagen. That's, again, necrobiosis is like a fancy way of saying collagen that's devitalized. Well, collagen's already extracellular. It's not even alive, right? It's a extracellular protein made by fibroblasts. So how do we know that collagen is dead when it's not really alive to begin with? Well, the way I think of it is that usually collagen has fibroblasts with it, right? So the dermis normally has a normal population of fibroblasts. But here we've got a bunch of collagen with like basically no fibroblast nuclei. So that's what I think of, is that when you have, it's pink and it begins to lose the fibroblasts, that's when I start thinking that's like necrosis of the collagen or necrobiosis of the collagen. People have pointed out that word is kind of a misnomer, and I agree, but it's a word that we've been using for a long time and I think is understandable at least. So this dead or degenerated collagen layered in between areas of histiocytes that are kind of lining up and forming like a fence or a barrier around the dead and dying collagen. That's the palisaded necrobiotic granuloma pattern. We see that in Granuloma annulare. We see it in rheumatoid nodule. We see it in Necrobiosis lipoidica diabeticorum. And we see it in this entity, NXG, or necrobiotic xanthogranuloma. So to me, NXG, which by the way is vanishingly rare in my practice, I think I've seen 1 or 2 cases in 12 years of practice. I've thought about it a handful more times, but only I think once or twice have I actually seen like the real deal in practice. So it's usually the dermis and or subcutis is involved by this palisaded necrobiotic granulomas. It has a similar appearance to NLD. To me, it has a lot of overlap because it's got layering of histiocytes, lymphocytes, plasma cells, and necrobiosis. The big differences are, number 1, clinical, which I'll talk about in a second. Number 2, these massive giant cells. That is, to me, the most useful clue. If it looks like NLD, but you have huge multinucleated 2-ton giant cells or foreign body giant cells, then think of NXG, okay? Clinically, though, NLD, necrobiosis lipoidica, is usually on the shins, right? The lower leg, sometimes in diabetic patients, sometimes not. NXG, this entity we're looking at here, necrobiotic xanthogranuloma, has a predilection for the face, particularly around the eyes. Like 80% of patients, I did some reading on this last night because it's one of these things that I only rarely see, so I don't have all the data points in my head. and I have to refresh it from time to time. So it about 80% are on the periorbital area. They also can be on the other parts of the face, on the neck, on the trunk, but less common to see on the extremities. And they start out as papules that then expand and turn into nodules and then plaques. They have a yellowish xanthoma-like appearance and are sharply circumscribed. Sometimes they ulcerate. And then these patients, what's the importance of recognizing this disease? What else do these patients have sometimes?
Amyloid.
Yeah, they could have oftentimes they have a paraproteinemia, which can go hand in hand with multiple myeloma or amyloidosis, right? And so the paraprotein is usually IgG kappa most of the time. And these patients may not actually meet criteria for myeloma or amyloidosis at diagnosis, but sometimes they develop a plasma cell abnormality even years later. So these patients need to be followed. They need to be checked for multiple myeloma or amyloidosis, and they need to also be followed over time to make sure they don't develop it eventually. They also may have anemia, low white cell count, high erythrocyte sedimentation rate, as you can imagine with all this inflammation going on. And sometimes it also can have an association with other types of lymphomas, like other B-cell lymphomas, including chronic lymphocytic leukemia, small lymphocytic lymphoma, CLL, SLL. And so what we see is we have zones of necrobiosis. Here's some actual proper necrosis, and then here's degenerated collagen. Layers of histiocytes with tons of giant cells, and usually you will see cholesterol clefts, which I think these spaces are. Some of these I think is artifactual cracking, but I think some of the needle-like empty spaces here probably represent clefts made by deposition of extracellular cholesterol and other lipids. You can have frothy lipid material. Probably there's some lipid in here as well. This kind of bubbly, frothy, cleared out spaces. So the necrobiosis and palisading with the giant cells and with the free lipid is what helps you, as does the clinical. And then those patients, like I said, they need further work. Oh, this was the area that I thought was probably the better. I think this is pretty good for cholesterol crystals here. All right, so this is a really nice example, and a very nice ample biopsy, I'd say. A nice example of NXG, necrobiotic xanthogranuloma. Case 8. One of my favorites.
I can do this one, and it's one that I hate the most. I feel like it's always so hard to like recognize this, and I feel like this cut is kind of odd. Just looking at it, but like at a distance, it just looks very pink and blue.
Very good. That's the first step to recognizing it. It's pink and blue from low power. Good.
Yes. And then, like if you kind of like zoom in on the bluish areas, it kind of looks like almost like a peppering, I guess, or clustering of lymphocytes. And like I know you're supposed to see them kind of like going into histiocytes or see like emperipoiesis. I always like struggle to recognize that. So I don't know, like I know it's Rosai-Dorfman, but I feel like it's still so hard. I don't know.
Well, that is fair, and that's because everyone tends to focus on teaching about emperipoiesis. Number one, because it's kind of weird. I happen to get lucky. I actually looked around for a while last night to try to find a convincing emperipoiesis because this question always comes up, and I just happened to land on a really good one right here. Here, this large, big nucleus with the cleared out, white-looking kind of chromatin, that is the classic cytologic feature of a Rosai-Dorfman histiocyte. They look different than other histiocytes. They're massive. They have really big nuclei with this cleared out, what we would call vesicular chromatin pattern. See, here's one right here. Here's one right there. Those are the cells of Rosai-Dorfman. Then they have abundant pale cytoplasm. The thing is that pretty much all of the cytoplasm we're seeing here, all of this is histiocyte cytoplasm. They're like forming a sheet. So all of the plasma cells and lymphs here are probably emperipoiesis. But they don't look pretty like the books, right? If you want to find good emperipoiesis like the books, like this case right here, or this one right here, this cell has 1, 2, 3, 4, 5, 6, 7 lymphocytes in its cytoplasm. That's emperipoiesis, but we are also seeing emperipoiesis everywhere we look here. It just doesn't look as obvious and pretty. If you really want to see it, you can do an S100 stain. So these, normally histiocytes don't express S100. Occasionally you can see some that do, but Rosai-Dorfman histiocytes usually express S100. And so S100 immunostain sometimes will help highlight the vacuoles. It'll make the cell stain. the cytoplasm and the nucleus, and it will show little vacuoles where the lymphocytes and plasma cells and neutrophils maybe are sitting in the little vacuoles. So it can sometimes enhance the ability to find imperipolesis. But the good news is you don't need to find imperipolesis to make this diagnosis. What you need is from low power, pink and blue, baby. That's what my former fellow Betsy Uhlenhake used to like to say. She would always say that. She's like, pink and blue, baby, it's going to be Rosai-Dorfman. And I thought that was great because from low power, that's what it looks like. Sheets of pale pink or pinkish gray histiocytes punctuated by aggregates of blue lymphocytes and plasma cells. That's the classic low power appearance. Most of the time when we see Rosai-Dorfman, and by the way, the Rosai-Dorfman was first described in lymph nodes, and it was called sinus histiocytosis with massive lymphadenopathy. Well, sometimes it occurs in soft tissue where there are no sinuses like a lymph node has. So that name doesn't really make sense there. So we call this extranodal Rosai-Dorfman. I let the hematopathologist deal with nodal Rosai-Dorfman. I basically stick to the soft tissue and skin version. Most of the time when I've seen it, it forms a mass in the subcutis like this. That's why you're seeing just a chunk of tissue here with fat at the edges but no skin. It can also occur in the dermis, but in my practice, I see it much more often in the subcutis. That also may be because I do both dermpath and soft tissue pathology, so I tend to see more of the things that are deeper nodules. All right, so when we go closer, the aggregates here are lymphocytes and usually lots of plasma cells. Plasma cells are essentially always present in this disease, and they're usually numerous, okay? And then, when I've got that low power, I'm already thinking of Rosai-Dorfman, I found my lymphocyte and plasma cell aggregates. Then what I want to go do is go look for the histiocytes with the huge pale nuclei. And there they are, right there. See, big nucleus, pale chromatin, usually with one or a few nucleoli in the center. Here's another big histiocyte, another one. They're everywhere. And then you can do S100 to help support the diagnosis. And then don't worry about the imperipolesis. If you find it, that's great. But I've hunted down imperipolesis to take photos for when I wrote my book. And I had to hunt for a long time to find a really picture-perfect example of imperipolesis. If we have to hunt that long to find something, then that means, is it really that useful of a feature? It's great when you find it, but don't hang your hat on it. Here's more right here. Here's some imperipolesis probably. Here's some right here. So it is there, but you have to look around. And I really think, like I said, I would propose to you that we're seeing it all over the place here. It just doesn't stand out as obviously because the cytoplasm of all the histiocytes is blending together. Now, Rosai-Dorfman, for a while, people debated whether it was reactive or neoplastic. I think it is recognized as probably being, oh, here's a good imperipolesis right here. Lymphs right in the cytoplasm of this big Rosai-Dorfman histiocyte. That's the picture to snap right there. There you go. So we now know, and one of my friends, Dr. Sofia Garces, was the lead author on this paper from the MD Anderson group, about Rosai-Dorfman, where they did molecular analysis and found that many cases have mutations involving KRAS or MAP2K1. So these are protein kinase pathways. So more and more we're discovering that different histiocytic diseases have abnormalities or mutations, and they're often involving various protein kinase pathways. So we've seen that with Langerhans histiocytosis and Erdheim-Chester disease, which can have BRAF abnormalities. And in Rosai-Dorfman, we can have KRAS and MAP2K1 molecular abnormalities. So we are discovering more about this. And so that paper, Sofia Garces did awesome work in helping to discover the importance of protein kinase pathways in this disease in Rosai-Dorfman. And a lot of times this is self-limited and kind of goes away on its own after a while, but there are some people that can have persistent or progressive disease. Sometimes you can get organ involvement, things like that. So it can be problematic sometimes, but in general it has a benign and indolent course. That's my basic understanding of it. Again, one of my favorites. Case 9.
I can do this one.
Okay.
Alright, so for this case, I think the site helps the plot with it too. There you can see kind of some skeletal muscle in it, and makes you think that you might be on the eye with some of the follicles as well.
Yeah, good. And there's a skeletal muscle right here with the peripheral nuclei. We can't really see the striations very well. Oh, here we can. There's some striations. So yes, near the eyelid is a good place to have skeletal muscle up in the dermis. And then here's the cells that are in the dermis.
And then those cells, you can see they're kind of foamy looking. It looks like there's some lipid inside, and so this would kind of make you think xanthelasma.
Yeah, very good. They're foamy histiocytes or xanthoma cells, histiocytes that have little bubbles of lipid in them. And sometimes it's a little hard to tell if a histiocyte is foamy and lipid vacuoles or if it's granular. There can be a little bit of overlap between those patterns. The thing that helps me is like foamy cells actually have like actual discrete little clear bubbles. And it's a little hard to see on this scan, but they often bump and indent into the nuclear membrane because they're lipids. So they're little bubbles, little spherules that are not dissolvable in water. So they're going to push everything out of the way, including the nucleus or the rest of the cell. So from low power, xanthelasma doesn't look real exciting, right? Because the cells are kind of pale, so their cytoplasm blends into the background. But you can see when you go closer, they really are like a bunch of histiocytes trickling in between the collagen. And they generally kind of preserve the dermal structures here. They just fill the spaces in between. They don't really destroy or push out of the way any normal structures. There may be a little bit of lymphocytic inflammation, but in general, xanthelasma is usually almost purely foamy histiocyte with very minimal inflammation or fibrosis or any other change, as opposed to some other things in the xanthomatous and granulomatous categories. And then these are almost always on or around the eyelid, the periocular area. And this is associated in about half of patients with xanthelasma have hypercholesterolemia, I think is usually what's associated. I think it can also be seen in other lipid abnormalities like hypertriglyceridemia. But about half of people have hypercholesterolemia, excuse me. So I for some reason, I actually thought it was higher than that. I thought it was much more strongly associated, but it's about 50-50. I just read last night to double check on that. So in any case, people with xanthelasma probably should get their lipids checked if they haven't. Okay. Number 10, something we do not see very often.
Take this one, Dr. Gardner.
Okay.
That low power looks like we had a punch biopsy, and what's standing out are these large clear spaces, some of which have this sort of like feathery frost on a window pane type look. And that is usually a sign of the necrosis of lymphocytes that are sort of aggregating with their material together. Surrounding that, you have a giant cell reaction that's reacting to that. And in the right clinical context, I think this would be good for a subcutaneous fat necrosis of a newborn.
Very good. Yes. So we see fat necrosis often in dermatopathology, or really any type of pathology where you're looking at fat. Fat tends to necrose if it gets damaged. And what we usually see is the fat cells break down. We see foamy histiocytes and maybe some giant cells around it. But what we don't usually see is this pinkish, pink to purple. In this case, is mostly, usually they're eosinophilic, but in this case they look a little more bluish. But this kind of like radial, spiky crystals that are crystalline kind of pink material replacing the dead adipocytes, right? That is something that we do not usually see in regular fat necrosis. And so the reason for that, or one of the proposed reasons, is because this is from a baby, right? This is a newborn baby, and this is fat necrosis of subcutaneous fat necrosis of the newborn. And what happens is the fat, where it's not entirely clear why this happens. Some people have proposed that it has something to do with temperature, with a cold temperature leading to damage of the fat. And the proposed idea is that infants have a different lipid composition in their adipocytes than adults do, and they have more fatty acids that are I think saturated fatty acids with a higher melting point, and so those fatty acids are thought to be more likely to crystallize and become solid if they get colder temperatures. So they're more sensitive to colder temperatures. That is one of the theories of why this could happen, but it's still, I think, basically considered to be idiopathic, but that's one theory about it. And I kind of like that theory because it does also explain why it looks so different, right? That the baby fat is different than grown-up fat. And so what you're getting is the lipids are crystallizing, and they make these kind of radial pink and white spiky structures inside the dead adipocytes, and then there's histiocytic and xanthomatous and giant cell reaction around it. So I can see here some nice foamy histiocytes. They've got bubbly cytoplasm, so they're eating up lipid also. I would say I have seen fat necrosis in a young child for a different reason. They had they were immune suppressed and had angioinvasive fungus. And they had fat necrosis because they were getting infarction of their skin from invasive fungi filling all the vessels. It was a horrible case. But they had a fat necrosis pattern that looked just like this. So I really like that idea that the fat is different in infants, and that's what produces this different pattern. Now, what is the one thing that I think has some overlap with this? And in my mind, I always have a hard time remembering how to tell these apart. And that's because it's kind of hard to tell them apart. But it's this disease, by the way, before we go on to that question, I did look up a few points on this. This is usually in the first few weeks after birth, and they're usually painless nodules that are symmetric. They're bilateral and symmetric usually, and they tend to be over the bony prominences. They could be the buttocks, the shoulders, the arms, the thighs, the cheek, and this process will usually resolve on its own within weeks to months. And for some reason, about 30 to 70% of these babies that have this have hypercalcemia. So they have increased calcium. They may have some other lab abnormalities as well. And again, it's not entirely known why this happens. Okay, so that's subcutaneous fat necrosis of the newborn. But what's the other disease that we need to make sure to not get this confused with, because it's much worse and is often fatal?
Is that Sclerema neonatorum?
Yeah, Sclerema neonatorum. I have never seen a case of that in practice, but I'm always worried about it because it's a baby that's involved, and the mortality is like 70, 80, 90%, something like that. And that is a disease where you also get necrosis of the fat. The books say it is with necrosis of the fat with minimal inflammation, but I'd argue that other than histiocytes and giant cells, there's not a ton of inflammation here. There's a few neutrophils, but not a lot. But the biggest difference from my reading, at least, is that in Sclerema neonatorum, you get these nodules that begin to make diffuse, firm, expanding plaques that are really firm and hard and waxy and feel kind of tethered and hooked onto the fascia, like they're not mobile nodules. So clinically, it presents differently. Rather than bilateral nodules over bony prominences, you get these thick, waxy induration that spreads. And so I think that's the big difference. But that disease is very bad and is often fatal. So it's an important distinction to make. But I have never seen a case of Sclerema neonatorum in practice, but it's one of those things that I always worry about and wonder how to tell apart. And that's what, from my reading last night, that's what it says. So, all right, case 11.
I can take this one.
Okay.
So from high power, you can definitely see some granulomas there. And then looking around, there is not a ton of inflammation around them. So I think these are naked or sarcoidal granulomas.
Very good.
And then I know the differential for this is pretty broad. I would look around for some foreign bodies.
Yes, excellent. But assuming no foreign body, bug stains are negative, cultures are negative, everything else is ruled out, what's this pattern the classic example of? Sarcoidosis. Very good. Yeah, so these are the naked, tight, packed together epithelioid and spindle histiocytes making nice, tight, aggregated granulomas with minimal inflammation. That's the classic granuloma pattern of sarcoid. This is like a prototypical example of a non-necrotizing. Usually they do not have necrosis. Every once in a while you can see a tiny bit. But usually non-necrotizing, naked, meaning lacking the inflammation, like you said, granulomas. That's a classic pattern for sarcoidosis. In real life, this is a diagnosis of exclusion, and we must exclude other things. I've definitely seen great sarcoidal granulomas in the setting of foreign body reaction. I've also seen sarcoidal granulomas in the setting of mycobacterial infection, right? So, and unfortunately, the kinds of mycobacterial infection where you get the nice sarcoidal granulomas are usually the ones where the patients have a good cell-mediated immunity and they kill off most of the organisms. So the organisms are very rare and hard to find, which is frustrating. It means you've got to hunt around forever. And sometimes you don't find any organisms, but then you do cultures or molecular and you find that there's organisms there. So like tuberculoid leprosy, for example, or actual tuberculosis. So good. So yes, in real life, we have to work these patients up, make sure they don't have anything else, and make sure that the clinical pattern fits for sarcoidosis. And in this case, the sarcoidosis granulomas are mostly in the subcutis, So kind of fancy name for that, if you like eponyms, is Dermatology disease, which is basically subcutaneous sarcoidosis or sarcoidosis type, like kind of mimics paniculitis clinically, but is actually a form of sarcoidosis. All right, good. Case 12.
I can take this one, Dr. Gardner.
Okay.
So at this power, again, we see just pink histiocytes scattered throughout the dermis, pretty superficial, too deep on this shave. What I can sort of see as we zoom in is there's sort of almost two distinct colors of cytoplasm.
Good.
Like a deeper pink fuchsia color and a paler pink color, sort of two-tone. And there are a few eosinophils scattered throughout there as well.
Yep.
So this is good for multicentric reticulohistiocytosis.
Yeah, so it depends on the clinical situation. If this is one lesion, we would call it a reticulohistiocytoma, a solitary reticulohistiocytoma. If the patient has multiple lesions, particularly like papules on the dorsal hand, then that's multicentric reticulohistiocytosis. And that form of the disease is often associated with severe arthritis that can be like really crippling and severe. The solitary form is generally not associated with anything else. I will say this is something that I rarely see. I've only seen a few cases in practice. Okay, you get a nodule, an aggregate of these very large histiocytes that are kind of epithelioid. I would definitely not fault you for doing a SOX10 or S100 stain to make sure these are not melanocytes. They look a little like, almost like spitzoid melanocytes a bit. They almost look a little like epithelial cells or like epithelioid sarcoma cells a little bit. So I would never fault you for doing some stains to make sure this wasn't something else. Because these cells are big and they look kind of atypical with their large nuclei and their prominent nucleoli. And they often have a variety of inflammatory cells mixed with them, including eosinophils. And for that reason, I feel like this, to me, reticulohistiocytoma has a lot of overlap with juvenile xanthogranuloma, to my eye. Usually in juvenile xanthogranuloma, you don't get as big, as plump, as epithelioid histiocytes. And usually you have more foamy cells, more two-tone giant cells, more fibrosis, more inflammation. But I feel like even though these things are probably two separate things biologically, they morphologically have some overlap sometimes. So if you're seeing something and thinking, ooh, could this be reticulohistiocytoma or JXG? If it's on a test, if you see a lot of EOs, although this case has quite a few EOs, but if you see a lot of EOs, a lot of foam cells, two-tone giant cells, and not as many of these big epithelioid-looking cells, then vote for JXG. If the opposite of that, then vote for reticulohistiocytoma, okay? I would also point out that, look at this, there is imperipolesis all over the place in this case. So just a reminder that imperipolesis, while it is a buzzword for Rosai-Dorfman, it can be seen in other things, including reticulohistiocytoma. I've seen it before in juvenile xanthogranuloma, and occasionally you just see it in random inflammatory reactions where you can see some neutrophils or lymphocytes caught up in the cytoplasm of histiocytes. So, and I love the point you make that I think the most helpful feature of these histiocytes is the two-toned or two-colored, not to be confused with two-ton, which is the giant cell with the multinucleated ring and the foam around the outside, but these are two-toned, T-O-N-E-D, two-colored histiocyte cytoplasm, that purpley fuchsia kind of color, and then the pale pink usually around the periphery. And I find that a pretty reproducible feature in the few cases that I've seen. So I like that. And you could ask, well, how do I know this is not Rosai-Dorfman? Well, I think the dense pink and purple color of the cytoplasm, that is very typical reticulohistiocytoma, like we're just talking about, as opposed to Rosai-Dorfman, which has very fluffy, light, pale cytoplasm, loose cytoplasm to the histiocytes. Okay? So a really nice example of a rare entity. Okay, case 13.
I can take this one.
Okay.
So it kind of looks like probably head and neck skin.
Yep.
You've got little follicles up there, and then very deep in the dermis you have a palisaded granuloma, which does look like it has some caseation at the This would include something like a deep GA or
Yep.
rheumatoid nodule, but with it being on the face involving the follicle, that would be lupus biliaris disseminata.
Yeah, very good. Yes, when I first looked at this slide without seeing what the answer was supposed to be, I thought rheumatoid nodule or maybe deep granuloma annulare versus, of course, infectious granuloma. We got granuloma that has a central area of necrosis or necrobiosis. And then out at the periphery, if you ignored that central area, these granulomas look just like sarcoidosis, right? They are like naked granulomas here. So again, you can really have a range of granuloma patterns in a given case. So yes, we would do infectious stains here to make sure that's negative. I would polarize it and look to see if there's any foreign material. And then of course we need the clinical information. So clinically, this is, like you said, from the face, and this patient would have multiple yellowish brown papules around the eyes or on the central face. And this is called several different names, okay? Like you said, lupus miliaris disseminatus faciae, which is why people do not like dermatology, because of these super long Latin names. The other name that has been given to it is acne agmenata, and more recently people have used this term figure, which is an acronym for facial idiopathic granulomata with regressive evolution. I looked this up last night, by the way, in case you're like, wow, how do you remember all that? No, I had to look it up. So in any case, in the past, I had kind of learned this as potentially being related to granulomatous rosacea. But clinically, it seems to be different. These patients have these often do not have other features of rosacea. So even though granulomatous rosacea can produce perifollicular granulomas microscopically, the clinical presentation of lupus miliaris / acne agmenata is different, I guess, than other forms of granulomatous rosacea. At least that's from what I've been told and from my reading. It seems to be the current thinking. If you cut deeper, sometimes you'll see that these granulomas are actually associated with the destroyed hair follicle. In this case, I can't really appreciate that, but that's what the, oh wait, look, maybe over here. Maybe this is actually a follicular epithelium, or maybe it's epidermis. I can't really tell. Sometimes when the tissue's twisted around, you can't really see whether that's the edge of a cyst or a cystic follicle, or if it's actually epidermis. So I'm not sure. But in this case, this clinically fit. But in real life practice, I would probably call this necrotizing granulomas and then give a comment with a differential diagnosis. I mean, that's what oftentimes granulomatous diseases, sometimes you can really decide exactly what it is, but many times I have to be descriptive and say, I favor this based on the clinical, but I can't 100% exclude infection, even though infectious stains are negative. And you really have to put all the pieces together. So these can be complicated cases to deal with in practice. And time consuming too, because hunting for mycobacteria, especially if it's a big piece of tissue, can be very time consuming and frustrating. All right. Case 14, another one of my faves. Go ahead.
So you can see a massive tumor, and from this perspective, you can see some of it is pretty pale.
Yep.
Go into a higher power, see these large histiocytes and almost kind of this like granular appearance to them. And as we get closer, you can see these granules within the histiocytes. This is good for a granular cell tumor.
Yeah, so these look like histiocytes, right? But what kind of cells are these actually? What a granular cell tumor? What is its origin? Anyone know?
Schwann cell.
Yeah, these are Schwann cells. This is actually, which is crazy, right? Because they don't look like Schwann cells. But this is actually a nerve sheath tumor. It will stain with S100 and SOX10. It will also stain with CD68, which is a marker that histiocytes stain with, but it's not a specific histiocyte marker. CD68 is a marker that stains phagolysosomes. So, of course, histiocytes are abundant in phagolysosomes, but other cells can have them too. So any cell with a lot of phagolysosomes will probably label with CD68 immunostain. So you really don't need to do that stain in this case, but the classic teaching for a test is that this granular cell tumor is positive for S100 and also SOX10, by the way, and CD68. And also, if you do PAS, it will beautifully stain these granules. In real life, I mean, really, this is an H&E diagnosis. There is another form of non-neural granular cell tumor that looks kind of like this. I think it looks a little different, to be quite honest, but if you wanted to make sure it's not that, both are benign. There are very, very rare malignant versions of granular cell tumor, but they're extremely rare. So if you see something that's a granular cell tumor but has a lot of mitoses or pleomorphism, then you can go read up. There's some nice papers out there that talk about the criteria for that. But yeah, these cells are look very similar to histiocytes, and could get confused with a xanthoma at first glance. But instead of them being bubbly, vacuolated cytoplasm, they have more like speckled, stippled, pink dots in the cytoplasm. Admittedly, that's a subtle kind of nuanced difference. And then also, they have these blobs, granular kind of globules in their cytoplasm, and those are called pustulo-ovoid bodies of Million, if you want to get real fancy, and if you like eponyms. So try that out on your friends at your next cocktail party and see what happens. That's what I like to say, at least. So the cells usually have round nuclei, central punctate nucleoli, and usually low mitotic activity. They may have random pleomorphism. That's okay, just like for neurofibromas, schwannomas, other nerve sheath tumors. Nerve sheath tumors in general will have scattered degenerative type nuclear atypia, scattered pleomorphism, but with minimal mitoses or other features to concern you for malignancy. So just random pleomorphism is totally fine if that's the only thing that you have. And again, you can read up about the mitotic rate and the other things that can make you worry about an atypical or uncertain malignant potential granular cell tumor or a malignant one, but the vast majority of these are totally benign, okay? The one other thing that I wanted to tell you, or two other things I wanted to tell you, wait, maybe three. Sorry, I keep thinking of more things as I say it. Okay, if it'll come back into focus here. This case doesn't have it, but a lot of times granular cell tumors produce really striking pseudoepitheliomatous hyperplasia in the epidermis. So the epidermis can grow down and look like a glassy, well-differentiated squamous cell carcinoma. So this is a particular problem and I feel like it's more common in mucosal sites. So one of the most common places, I think actually the most common place for granular cell tumor is the tongue. So on the tongue, I feel like it's more often when I've seen granular cell tumors on the tongue, they often have the pseudoepitheliomatous hyperplasia. In the skin, I would say actually only a minority of the cases I've seen have it. So this case doesn't have any, but just know that they can produce, they can be a mimic of squamous cell carcinoma. And the key is if you think it's a glassy squamous cell carcinoma, look in the dermis or in the submucosa if you're in the mucosal site, in between the keratinocyte aggregates and look for granular cells there. I saw a case once on the bottom of the foot and it mimicked a wart. It made instead of it looking like a squame, it looked like a verruca. The other thing is that at the periphery, granular cell tumor, even though this looks kind of circumscribed from low power, essentially always these have a feathery, almost, quote, infiltrative border. And I don't like to use the word infiltrative because it sounds bad, but what the cells kind of crawl between the dermal collagen, the reticular dermal collagen bundles. So they normally intercalate with the collagen at the periphery and kind of trickle out at the edges and are not like encapsulated or sharply circumscribed. And the third thing, and I can't show you, I don't know if this case has it, is it's very common to see granular cell tumor growing around nerve bundles at the periphery. And that's because it's a nerve sheath tumor. So normally, we get worried when we see stuff grow around nerves, but it's totally normal for nerve sheath tumors to do that. And so if you see that, don't be worried. It's like present in almost 90% of cases if you look around enough. So you don't need to find that, but just if you notice it, don't freak out. That's not bad. It's not a worrisome finding. Okay. And this is case 15.
I can take this one. Again, like really deep process. A little bit like necrotic or in the center. A little closer. Yeah, it's like this fibroid necrosis, all this like dark pink material.
Yep.
For this pattern, you kind of think about a couple different things when you start kind of hunting for mucin as well.
And here it is.
Yep, there it is. So this one would be like, rather than a rheumatoid nodule, which clinical would help with that is 2, this would be like deep GA.
Yeah, so that's exactly the differential. Is this either a big juicy example of granuloma annulare, or is this a rheumatoid nodule? So I feel like those two entities can look essentially identical to each other, okay? The classic teaching is that pink, I was talking earlier about palisaded necrobiotic granuloma, dead degenerated collagen in the middle here, and then histiocytes around the outside and kind of these irregular islands. It's like a big kind of a lake, an irregular lake made of dead and dying collagen, surrounded by a shore made of histiocytes. But in this case, they really line up and actually palisade. So, you know, a lot of times you say, oh, it's palisading, kind of. That's the real deal palisading, right? Lined up in layers and kind of stacked almost vertically around the necrobiosis. Beautiful example here. So the biggest differential for this palisaded necrobiotic granuloma, when it's like this well formed, is granuloma annulare and rheumatoid nodule. And if the center is mostly red fibrinoid necrotic or necrobiotic material, then we would vote for rheumatoid nodule. If it's more blue mucin, then we would vote for granuloma annulare. Well, what do we do in this case? We've got bright red fibrinoid stuff and also a bunch of mucin, right? So from the answer sheet, I know this is supposed to be a rheumatoid nodule. And the real life practice answer is it really depends on the clinical. If a person has known rheumatoid arthritis, then it's going to be probably a rheumatoid nodule, right? If the person is a child and they don't have rheumatoid arthritis, which is rare but can occur in kids, but if it's a kid and they've got a deep nodule on the leg and it looks like a rheumatoid nodule, but they don't have any signs or symptoms of rheumatoid arthritis, then it's probably deep granuloma annulare. So on a test, if it's more red in the center, rheumatoid nodule is the answer. If it's more blue in the center, granuloma annulare is the answer. In real life, though, it does depend. I would say that classically, rheumatoid nodules are taught as being down deep in the subcutaneous or even down near the joint space. But I've seen many examples that also involve the dermis, just like I've seen GA that's totally centered in the subcutaneous without dermal involvement. So it can go either way, all right? The one thing here that I do see that is I see more often in rheumatoid nodule than granuloma annulare is neutrophils. See the neutrophils scattered here? Normally we teach that neutrophils in a granuloma, infection until proven otherwise. But usually, in my experience, infectious granulomas do not really produce this palisaded necrobiotic granuloma pattern. I have seen one case that looked kind of like a rheumatoid nodule that actually was AFB, but most of the time that is not the case, all right? So, but I would say that neutrophils are actually usually present in rheumatoid nodules. Not usually like frank pus. They're just kind of scattered and trickled in there, usually with some nuclear dust. But that's pretty common to see. And you can also see plasma cells. Sometimes you can see vasculitis in the background because patients with rheumatoid arthritis sometimes have rheumatoid vasculitis. So that's good to know about. In real life, though, if I'm not sure, I will sign it out as palisaded necrobiotic granuloma, and that this could represent either rheumatoid nodule or granuloma annulare, and it depends on the clinical, and then they can work up the patient and see if they have any signs or symptoms concerning for rheumatoid arthritis. All right. And if there's concern about infection, you could do bug stains or you could have cultures done. Kind of depends on the clinical setting to me. Okay, so in this case, it was rheumatoid nodule, but. And what's the bad thing? There's a tumor that can grow kind of in a pattern like this, and is always important to keep in your differential when you're thinking about deep GA and rheumatoid nodule. You always want to make sure to ask yourself, is there any chance it could be what?
Epithelioid sarcoma.
Very good. Epithelioid sarcoma, which at closer look has much bigger, more atypical cells, but it can grow very much in a pattern that looks very similar to rheumatoid nodule. And thankfully, you can use immunostains like EMA and pancytokeratin, and depending on those results, INI1 or SMARC-B1 to help identify that tumor. It's just an important thing to keep in your differential. It's very rare, but it's very bad, so you don't want to miss it. And I've got other videos about that. You can check out the links down below if you're watching this online. 16. And wow, this from low power is like the best example ever. Unfortunately, the slide's faded and doesn't look as great at high power, but it doesn't get better than this from low power. Okay, so what is this?
A nice layered NLB.
Yes, this the beautiful layering of Necrobiosis, lipoidica, diabeticorum, or sometimes people drop the diabeticorum because it's not always in diabetic patients. These are usually kind of firm atrophic plaques, which I know that's a little bit of a misnomer to say, but I don't know the other word to call something that's atrophic but still firm. So I think of it kind of as a negative plaque, if you will, a plaque that's pushed into the skin. So they tend to be firm, kind of atrophic areas, often on the shins, often bilateral, but not always, and they have kind of a yellowish, reddish, brown appearance, depending on the case. And then when you do a biopsy, what you see is layering of degenerated necrobiotic collagen and fibrosis and sclerosis layered in with granulomas, histiocytes, lymphocytes, and plasma cells, kind of layering in all the way down through the dermis and down into the subcutaneous. So this is the classic low power pattern for NLD, okay? And when you look closer, you'll see that the histiocytes, they may like make kind of well-formed granulomas. Other times they're very loose, kind of lymphohistiocytic infiltrate. It kind of varies from case to case. You may see foamy, you often see foamy cells. You may see some additional lipid. There's often fat necrosis in here because it involves the fat. Some giant cells scattered in here. This is a really good example. And my former colleague Sarah Shalin, she told me something one day that I really liked. She said she kind of envisions NLD as actually being like a very big palisaded like granuloma that's a big oval kind of stretched out like for the whole plaque. And that if you punch down through it, we're just seeing like the layers of it, but at the ends it may actually loop around. I don't know if you can visualize that. If she had drawn it out on a chalkboard, and I thought, ooh, I love that they're like multiple kind of squashed oval shaped granulomas, and we're just punching down and seeing like layers of them in the middle. Because sometimes this can have some overlap with rheumatoid nodule or granuloma annulare. So most of the time, if it's obviously layered like this and it fits clinically, it's very straightforward. But occasionally I've had to also say necrobiotic palisading granuloma, could be Necrobiosis lipoidica, but there's also overlap with rheumatoid nodular GA. Again, most cases it's pretty straightforward, but I have had a couple that I wasn't totally sure. So a really good example of Necrobiosis lipoidica. (17)
I can take this one.
Okay.
Okay. So this power, I see there's a lot of like a bluish, and there is some like this collagen, like a pink color.
Yep.
And I mean, it's mostly the lesion is in the dermis.
Good.
And this power, I see like these are like a foamy cells, lipid-laden histiocytes.
Yep, very good. Foamy cells. And what about these?
See, like if we have these two-tone giant cells, yes. So
very
we have
good.
Two-tone giant cells as well. So yeah, with this like lipid and foamy histiocytes, and then like some inflammation in the background, also with two-tone giant cells, that would be juvenile xanthogranuloma.
Yeah, very good. Juvenile xanthogranuloma, JXG, also known as solitary xanthogranuloma, because even though they're more common in kids, they also occur in adults. But solitary is not really a proper name either, because sometimes they can be multiple. So, you know, no names are perfect, but xanthogranuloma, I still call them JXG, even though they can occur in adults. And they will have a mixture of plump kind of epithelioid histiocytes that can look a little similar to the histiocytes of Reticulohistiocytoma. Like, for example, look. Here's some big histiocytes with two-toned, two-colored cytoplasm. See, I feel like there is overlap microscopically between Reticulohistiocytoma and JXG. But usually you have a minority of those cells and more of other cells. So it's a mixture, and each case varies from case to case. But you get a mixture of foamy xanthomatous cells or foamy histiocytes, non-foamy histiocytes, inflammatory cells, predominantly lymphocytes, and also usually eosinophils, and then classically two-tone giant cells. So you can have all of those in varying amounts, and they fill the dermis and kind of ooze in between or crawl in between the reticular dermal collagen. They kind of fill in all the spaces. They leave the dermal structures intact and fill in all the space in between. In more advanced lesions, they can become fibrotic and more spindly and have fibroblasts. I guess I forgot to include that. Fibroblasts are also present. So some lesions become relatively fibrotic and begin to look kind of like dermatofibroma. Some earlier lesions are almost entirely foamy and they can mimic xanthoma. Or I've even seen cases that look really similar to cutaneous mastocytoma, actually. I've seen cases that had no two-tone giant cells. I've seen cases that had almost no eosinophils. Then I've seen other cases that had more eosinophils and two-tone giant cells than you could possibly imagine. Well, I mean, I've got a pretty good imagination. I can imagine a lot. But the point is they really run a range between high and low cellularity, tons of foam, a little foam, tons of eos, very few eos, tons of two-tons, very few. So just keep in mind that each case may look a little different. But ideally, look around and hopefully you'll find two-tone cells and hopefully you'll find eos. And a two-tone giant cell, just for the record, is a multinucleated giant cell that has a ring arrangement of the nuclei, but not just is it a ring, in the center of the ring is kind of homogenized eosinophilic to amphiphilic cytoplasm. On the outside of the ring is a layer of bubbly foam. So it's like a smooth, creamy candy filling and a crunchy, crispy candy shell on the outside. So I heard Dr. Rapini say something like that one day. I think he just like said it off the cuff, but I thought it was a great explanation. So I've now stolen it and passed it on to all of you. Juvenile xanthogranuloma. And there is a really weird thing. If a child has multiple juvenile xanthogranulomas and also has neurofibromatosis type 1, they are at risk for getting something else that seems totally unrelated. And what is that? This is a weird, esoteric question for the boards, but also occasionally has had real life significance in detecting disease.
I think I know it.
Okay.
It's JMML.
Yes, juvenile myelomonocytic leukemia, JMML. For whatever reason, and I still don't really understand how to wrap my brain around this, people with NF1 that get multiple JXGs have a risk of developing this uncommon type of leukemia. So strange, huh? All right, so that is a JXG, a good example. Next case. All right.
So, yeah, this one, we have like a purple lobule, maybe multilocular looking lobule from here.
Good.
With some dense collagen kind of going through parts of it.
Yeah, very dense collagen.
Then we start seeing these like cells that are jumping out to us, distinct from the rest, and they're like these multi-nucleated osteoclast-like giant cells, and that in and of itself makes me think of like giant cell tumor of the tendon sheath.
Very good.
And then you could look for hemosiderin.
Very good, yeah. So this is a giant cell tumor of the tendon sheath, also known as tenosynovial giant cell tumor, localized type. There is a diffuse type, but it's more in big joints and deep soft tissue, not really a dermpath entity. I will say that this is something that in dermpath you rarely ever see unless you do soft tissue stuff also, because usually these are deep nodules attached to dense regular connective tissue, tendon sheath fascia, down deep, right? So this is part of the tendon sheath or tenosynovium, which is where these usually arise from a tenosynovial lined tendon on the hands or fingers or the feet or toes. Occasionally you can see them in other bigger joints or arising off of a bursa in deep soft tissue, so you can see that. They rarely ever involve the dermis, although I have seen a case that actually pushed up. It was like on the dorsum of like one of the toes, and it pushed up and made a skin polyp and was shaved off by a dermatologist. So they can occasionally get up into the dermis, but most of the time they are not. They are usually going to be down deep, and you're not going to see any skin on the slide. So for a test, if you see a nodule that has giant cells in it, is attached to a tendon sheath or some dense regular connective tissue, has no epidermis over it, the answer you should say is giant cell tumor of tendon sheath. In real life, there are other things that can have giant cells. There's a giant cell tumor of soft tissue, which is not related to this, but can have a little overlap. And you can also have cases of this where you have very few or no giant cells. So because of that, it's important to recognize how to identify this when the giant cells are very rare or absent. So the thing is that it's interesting here is the giant cells are not the neoplastic cell. They're just hanging out. The neoplasm cell, the cell with the molecular abnormality, is actually these histiocytes, these mononuclear histiocytes that have abundant cytoplasm and an eccentric nucleus. They look kind of plasmacytoid or almost rhabdoid because of that eccentric nucleus and the abundant cytoplasm. Those are the actual neoplastic cell. So I want to see those cells in the background. They can be very mitotically active, sometimes have numerous mitoses. They may have a variable amount of inflammation. They usually have dense collagen in the background. They tend to get areas where the cells kind of fall apart and become discohesive, like you're seeing in here, like the cells kind of are falling apart and floating around in empty spaces. There will be multinucleated giant cells usually, but some cases they can be very sparse. Usually there will be foamy histiocytes or xanthoma cells around the outside, and I looked for a while in this case and couldn't really find those. And then usually there will be hemosiderin present, at least focally. Sometimes it is very abundant. Here's hemosiderin. And then the hemosiderin has a tendency to do this weird thing where it makes a halo or a ring around the periphery of these tumoral histiocytes. So I've got some really good pictures to show you of this here. And if this doesn't make you happy, nothing will. So these cells, I call these hemosiderin halos, but they've also been called ladybird cells, which is like the British word for ladybug, because sometimes you get like two nuclei, and so they look a little bit like a ladybug, I guess. Like, see, here's the two nuclei, and then there's cytoplasm there. So almost nothing else does this except tenosynovial giant cell tumor. I think I've rarely seen something like this in a joint that had some hemarthrosis, and it was not a giant cell tumor. But almost never, if I see that, this is basically close to pathognomonic for tenosynovial giant cell tumor of tendon sheath. All right? So that's a really nice example. And I've got more pictures here. This is on Kiko. You can go look at that if you want. And I've got a long video about this entity if you want to see more examples. Case 19. And this is a perianal polyp. I'll give you some history here. So just an inflamed skin tag or something else?
Anatomic site in mind. At low power, we have this exophytic nodule that's characterized by this dermal process of pretty darkly staining granulomas. Differential is pretty broad when we go in deeper, though. However, we see these giant cells that seem to contain these inclusions that may be composed of protein and calcium. Given the site and given the histology, I think this would be good for cutaneous Crohn's disease.
Right. So basically, these granulomas in the dermis. If you see granulomas in the dermis in the anogenital skin, always think about the possibility of cutaneous involvement by Crohn's disease. All right. So sometimes it can be in like a perianal polyp, like in a skin tag. Sometimes it can be next to a fistula site, because patients with Crohn sometimes get fistulas. But I think it's always important to keep in mind, I see a lot of skin tags and a lot of inflamed skin tags. I do not usually see granulomas in skin tags. So if you see granulomas in this setting, always think about that. Of course, also there's other possibilities if people have like a perianal fissure or something, and some fecal material gets into that. Sometimes plant material can get caught up in the ulcerated site, and then you can get granulomas from that. So there are other reasons you can have granulomas. But to me, anytime I see granulomas of kind of any pattern in the anogenital skin, and I don't have a good explanation for it, I want to at least raise the possibility so that they can work the patient up if they have any signs or symptoms clinically concerning for Crohn's disease. All right. So this is, and sometimes people in the past have called this like metastatic Crohn's disease, which I think is a terrible, confusing name. So I highly recommend against using that. I just call this cutaneous involvement by Crohn's disease. Very good. Okay, case 20.
This is gel foam. You can see here, and the gel foam here, it looks like maybe a punch biopsy, and they just stuck the gel foam in there, starting to heal over.
Perfect. Yeah, so you can do that at a punch biopsy site. I've been told that you can, instead of stitching it, you can just plug the punch site with gel foam, and that it heals up really well. I'm not a dermatologist, but that's what I've been told by good dermatologists. So I believe it. But gel foam stays around in the tissue for a little while and leaves these purple, kind of jagged, curvy, I don't know, like ninja throwing stars or something. I'm not sure how to describe this stuff. Kind of serpiginous purple material with spaces around it, and usually a granulomatous and giant cell rich reaction. And so that's what it is. So it's just the gel foam with healing biopsy site changes. 21. This is a pretty good case.
At low power, we have a punch with action going on in the upper dermis. And, from this power, I could think about a lot of things. It looks like we have this almost necrotic and amorphous area with granulomas. The granulomas remind me a little bit like they're sarcoidal in some areas.
Agree.
inflammation sounding or surrounding it. So I think I would go closer, look for foreign material versus organisms. And when we go to low power, we have this punctate red material, and I think that could be good for a tattoo granuloma.
Yeah, very good. So this is red tattoo pigment, which is historically the pigment, the tattoo pigment color that is more likely to produce a tattoo reaction. Because at least in the past, and I don't know if this is still the case, but red tattoo pigment was made from cinnabar, mercuric ore, and for some reason that's a relatively immunogenic and tends to produce a reaction. Although I have some friends who are tattoo artists, and I asked one of them how often they've seen a patient, a client come back with a tattoo reaction, and they said that they had never actually had a patient come back that they can recall. And I would think that a person might come back and be upset about it, even though it's not the tattoo artist's fault that their immune system reacted to it. So I don't know. I guess I've certainly seen a fair number of biopsies over the years of it, but in dermpath we have a very distilled example of things that are atypical enough to come to the doctor and then get biopsied and then get sent to us. So sometimes I've seen things that are still very uncommon in the actual general population. So in any case, when this is like you said, the granulomas here look kind of tight and sarcoidal. Over here, though, we've got necrosis. And then also there's over here brisk inflammation in the background. So we got a kind of a variety of patterns here. And tattoo pigment is easier to see, I think, when it's black or a dark color. The red is easy to kind of overlook because from low power, I mean, I think our brain sees it and thinks, oh, it's just, some red blood cells or debris or something else. But once you go and look and recognize it, it really has a unique kind of stippled appearance, but it can be easy to overlook if you're not thinking about it. So and most tattoo pigments, their composition do vary, I think, from vendor to vendor. But most of the tattoo pigment that I've seen was not birefringent under polarized light examination. So usually that has not been helpful to me in identifying it's a tattoo. If you can see the clinical photo or get the clinical info, then usually it's a little more helpful. All right, the one thing I will say is that most of the time when I have seen tattoo reactions, it looks more like this here. Really robust, briskly inflamed, lymphocyte predominant, or lymphohistiocytic infiltrate with maybe some EEOs and other cells, and it's really robust lymphocytes. So a very brisk inflammation without actual well-formed granulomas most of the time when I've seen tattoo reactions. And I've seen, this case has a little bit of it, but sometimes there can be really robust lymphocyte exocytosis into the epidermis overlying it. And it can be enough that it mimics the epidermotropism of mycosis fungoides. So I have a case on Kiko, and I think I have a video of it on Kiko and YouTube that shows that kind of a pseudo-lymphomatous tattoo reaction. It was actually a patient that had such a severe reaction, they had to excise the entire tattoo. They could not get the inflammation to stop, and they had to remove the area that was inflamed, which was pretty terrible. So, so thankfully not common, but that can happen. If I, on the other hand, see purely sarcoidal granulomas with minimal inflammation at a tattoo site, I'm actually going to be more inclined to think that that might be a patient with actual sarcoidosis who's getting tattoo involvement because of the trauma of getting the tattoo done. And I would want the patient to be worked up for sarcoidosis to check, do a chest x-ray maybe and do some additional workup to see if the patient could have sarcoidosis. Because we know sarcoid involves sites of trauma, and a tattoo is micro trauma of the skin. So I feel like a lot of times if I just see purely sarcoidal granulomas, I'm more inclined to think that it's maybe sarcoid involving the tattoo rather than a tattoo reaction. I guess you could kind of ask the question of, how do we define those things? What's the gold standard? I don't know. But most of the time when I've seen tattoo reactions, they were briskly inflamed and usually without the well-formed granulomas like we see here. So this is a really nice example and a good example too with the red pigment in here. So that's a pretty great case. '22.
So here we have action is mostly in dermis. And on this power I see there's kind of like a foamy cells.
Good.
So I want to go high power and see if we have. So yeah, so here we have like a foamy histiocytes, and then we have this pink fibroblast as well. And then we also see like there's some extracellular lipid as well.
Good.
So the logic behind is like there's a lot of lipid deposition in dermis, that histiocytes gets overwhelmed, and then they have like some extracellular lipid in the dermis.
Excellent. So what is this good for?
Good for eruptive xanthoma.
Yeah, very good. Eruptive xanthoma. So obviously the best way to know eruptive xanthoma is that clinically eruptive means suddenly multiple lesions coming up. Generally when we use the word eruptive, that's what it means. But this eruptive xanthomas have a microscopic pattern that can kind of clue us in to the diagnosis, thankfully. That's what we're seeing here. Okay, the pattern that we're looking for is the extracellular lipid. Because otherwise, if you just have this looks just like a xanthelasma. It's just foamy histiocytes in the dermis, in between the dermal collagen, right? So the key is either clinically knowing the history that it's eruptive, and oftentimes, usually, these will have free kind of frothy stuff, which is extracellular lipid in the dermis alongside them. That's the classic finding, although it depends on like when you biopsy the lesion. Sometimes they don't have this, supposedly. I've not seen very many of these. They're not something I've encountered often in practice. Here's some more extracellular lipid there. And so these usually are 1 to 4 millimeter yellow papules, and they classically are supposed to have a red halo around them. They usually are on the buttocks, the shoulders, the extensor limbs, and they arise as a sudden onset of crops of the papules. They may wax or wane based on the serum lipoprotein levels. And then usually within a few weeks or so, they'll actually go away and resolve. And these are classically associated with hypertriglyceridemia. Elevated triglyceride levels in particular tend to produce this pattern of eruptive xanthoma. All right, and that's what this extracellular lipid here is mostly triglycerides, not cholesterol. So I guess most other xanthomas, the predominant lipid is cholesterol, and in these it's mostly triglyceride. All right, so that's a nice example of an eruptive xanthoma.
There's a lot of inflammation up and down throughout the dermis. We get a deep punch biopsy here, but you can see the Gren zone from here. And then if we zoom in, well, there's Gren zone. You can see the hair follicles. See the inflammation. The inflammation when we zoom in is mixed, and then that kind of comes together for granuloma faciale. And some of these areas do look like granuloma-like as well.
Yeah, you're right. In this case, it actually does look like there's kind of granuloma here, but usually I would say that granuloma faciale, the granuloma is in the name only, right? There are histiocytes in it, but you don't usually see well-formed granulomas in granuloma faciale. So the low power, like you said, is that you've got infiltrate kind of filling up the dermis, but preserving the structures. And I think that's a kind of a theme that we've seen in a lot of these things. Histiocytes and inflammatory cells can trickle in between the collagen and kind of surround but not displace the other the normal dermal structures. You can see that same thing with lymphomas and leukemias too. Sometimes they just fill in the spaces without always pushing other stuff out of the way. Unfortunately, we got a little fold up here, but you can tell that there is a little grens, a zone of uninvolved dermis right there. Usually, I don't find the concept of Gren zone very helpful diagnostically. It's a classic finding that's taught in dermpath, but I don't talk about it very much because I don't find it that helpful. But yes, it is true that in granuloma faciale, you usually do have this little zone of sparing where the infiltrate doesn't go all the way up to the epidermis. It kind of leaves a little band of dermis uninvolved and a space between the epidermis and the process. And then close up, like you said, it's a mixed infiltrate, histiocytes, lymphocytes, eosinophils, plasma cells. The most helpful thing to me is the neutrophils and the way the neutrophils are here, because we see lymphs and histiocytes and eos and stuff in lots of different things, right? But what we don't usually see is neutrophils evenly scattered throughout that kind of an infiltrate. We may see like aggregates or, like little pockets, little micro abscesses of neutrophils. But in G. faciale, even though in some areas they are kind of clustered, in many areas you were seeing like a peppering or scattering of neutrophils mixed in with all these histiocytes, lymphocytes, and eosinophils. And to my eye, that is a pattern that is really unique. And I don't usually see that in other inflammatory things or infectious processes. It has a distinct look. Once you've seen a few cases of this, I feel like it has a really distinct look. And so, yeah, you would want to make sure that you thought about infection or other things if you see this, but usually this pattern is pretty distinct. And so the scattered neutrophils in this mixture of other inflammatory cells, and it's usually kind of a reddish-brown, indurated papule or plaque or nodule on the face, and that's granuloma faciale. Sometimes you can begin to see some vasculitis and perivascular fibrosis in this setting, and that's because the other entity, which may have some relationship to this, is erythema elevatum diutinum, or EED, and that is more fibrotic nodules, usually on the extremities, and is a kind of a fibrosing vasculitis, but it can have some microscopic overlap with granuloma faciale, and some people have proposed that there may be some sort of link or relationship between them. So just so that's on your radar as a thing that could maybe look a little bit similar.
Try this one, Dr. Gardner.
Okay.
At this power, we see probably a shaved biopsy with a lot of inflammation, and a lot of things are kind of going through my head at this point. Differential would include an atypical lymphoid infiltrate.
Yep.
And it looks like there's some spongiosis. I can't really get to a diagnosis on this power, so I want to go a little closer and try to ascertain what type of cells are characterizing this infiltrate. And I see there's a lot of different cell types. There's EOs, there's lymphocytes, and then there are these larger cells that maybe have some reniform features, maybe some coffee bean-like type look.
Good.
So for that, I would think this could be a Langerin cell histiocytosis, and I'd want to get stains such as S100, CD1A.
Excellent work. So yeah, this is Langerhans cell histiocytosis, I agree. From low power, I would not know right away what this is. I would definitely think of a lymphoma or leukemia, something like that, because it's so dense and blue. Maybe a really exuberant bug bite reaction. I might think of a lot of things. But the one thing that Langerhans cell histiocytosis usually has is it usually has the papillary dermis filled with Langerhans cells. So that is kind of a unique feature. The other thing that usually fills the papillary dermis is mastocytosis. Okay, so those are two diseases that will give you an infiltrate that tends to pack the papillary dermis full of cells. And then it may extend well deeper into the dermis, but usually it starts with filling up the papillary dermis. So the two things that can help, well, three, we can do stains to help tell those two things apart. But one thing that helps, maybe it's on the other piece, where was that? One thing that helps is that Langerhans cell histiocytosis not only fills the papillary dermis, but it also usually trickles up into the epidermis. It does not respect the border, the boundary between the dermis and the epidermis. And that makes sense because Langerhans cells normally live in the spinous layer of the epidermis. So they can freely cross over the basement membrane and go back and forth between the dermis and the epidermis. So that's something that Langerhans cells do and mast cells do not. The other thing is that cytologically, even though they both are cells that have like kind of oval nuclei and abundant pale cytoplasm, the big difference is the nuclear shape. In Langerhans cells, you get these bean shape or reniform or coffee bean shape or grooved nuclei. And in mast cells, you don't, you just get more like oval shape. And mast cells have granules, although they're not always easy to see. In Langerhans cells, you can't really see much in the way of granularity. Eosinophils are usually abundant in Langerhans histiocytosis, but you can have them in mastocytosis as well. Okay, so you can do immunostains to identify that these are indeed Langerhans cells, and so S100 will stain them usually. And people often teach Rosai-Dorfman and Langerhans cell histiocytosis together because they're both histiocytic processes that are S100 positive. But they don't really look anything alike otherwise. The way they present, the way they grow, usually Rosai-Dorfman's deep in the subcutis. You can occasionally have nodules in the dermis, but whereas Langerhans cells usually is in the papillary dermis, the shape of the nuclei is very different. So I can't remember a time where I've seriously considered Rosai-Dorfman and Langerhans in the same differential diagnosis on a real life case. So it's fine if you want to learn them together because they're both S100 positive, but just recognize that they really don't look alike at all. So if you're watching this, that's something that I often feel like we are teaching to trainees, but making them think that these two things could get confused with one another when really they don't. So yes, so the CD1A is a marker of Langerhans cells, and then Langerhans, CD207, is also a marker. And so Langerhans is actually a molecule that's involved in the production of Bierbeck granules, and that's why Langerhans cells have Bierbeck granules on electron microscopy. But usually we don't do electron microscopy for skin biopsies anymore, so you can just use Langerhans as a surrogate marker for Bierbeck granules. Okay. And this is a disease, as you remember from med school, that can have a lot of different presentations. Sometimes it involves the skin only. Sometimes it can involve the lungs, the bone, the skull base. There are different types of presentations, some of which is more indolent and some of which can be quite aggressive and problematic for the patient. So these patients need clinical workup to determine what type they have. And occasionally it will come up that you can have a rich infiltrate that it has abundant Langerhans cells, but might not be this abundant. And I've had cases before where I've been left wondering, is this Langerhans cell histiocytosis, or is this just spongiatic dermatitis with a bunch of Langerhans cell microabscesses? So that's only occasionally as that happened, but I have had times where I've struggled to know how much is enough to call Langerhans histiocytosis. So one thing that is supposedly helpful is that Langerhans histiocytosis usually is positive for cyclin D1 by immunohistochemistry, whereas normal reactive Langerhans cells are not. So I have not, since I learned that, I've not actually encountered a case that to test that out on that I can recall. Oh, I guess I have, but I don't think I ended up doing it because it was like in the bone and it was very straightforward. But in any case, a good friend of a dermpath who's a friend of mine, Ben Wood from Australia, he taught me that little pearl and said that it works really well, and he's used it in practice successfully. The other thing is that Langerhans cell histiocytosis often has activating mutation in the BRAF gene, just like melanoma, the V600E mutation. And I think there may be other variations, but that's the one I think that is most common. You can look that up and double check me on it. So that's the other thing is you can do BRAF mutation analysis. You should not have a BRAF mutation in benign reactive Langerhans cells, right? So if mutated, that supports Langerhans. I would point out, though, there are other histiocytoses, particularly Erdheim-Chester disease, which I have never actually seen in real life, but my understanding is that it looks different. It does not look like Langerhans cells. It looks more like foamy histiocytes, but it also can have BRAF mutations. So BRAF can be really helpful in supporting a diagnosis, but not all cases have it. So if BRAF is negative, that doesn't totally exclude the possibility. All right. So this is a great example of Langerhans cell histiocytosis, and I did pull up some pictures here to show you from other cases that we have a little bit better cytologic features. So these are some where you can see extensive upward scatter of Langerhans cells, and guess what? If you did S100, you might think this is melanoma. The kind of epithelioid, there's quote-unquote pagetoid spread, but they will be negative for SOX10. So just remember, these are one of the things that can be S100 positive, but SOX10 negative. So, and here's a really good example of the cytology with the bean-shaped nuclei. And so depending on if you cut it in kind of cross-section, it looks like a bean, like a kidney bean or a kidney shape. If you flip the cell 90 degrees, it will have more of a kind of coffee bean with a linear groove sort of configuration, which I think you can kind of see like in this guy right here. And here's some that have grooves in them on this case. There's some kind of linear grooves. So those are some, oh wait, there's a good one down here that is kind of grooved. So that's a nice example of some other pictures of Langerhans histiocytosis. All right.
GA to me from low power.
Agree.
Palisade. And I think it continues to look like GA to me until we look really closely.
Yeah, here looks just like GA, right? Palisaded granulomas with central kind of necrobiosis. It's a faded slide, but I bet there's probably some mucin in here. But up here, what's happening?
There's some elastophagocytosis.
Yeah. We got solar elastosis, and the individual fibers of elastosis are getting kind of wrapped and eaten up by the giant cells. Here, you can see it on H&E. If you want to make it even more pretty, you can do an elastic stain, but you really don't need that. It's pretty obvious on H&E usually. There's a couple different names we could use that depends a little bit. So you could either call this annular elastolytic granuloma, or you could call it actinic granuloma of O'Brien if you're into eponyms. And to me, I kind of personally think, and there may be more expert people out there that disagree with me, but I kind of think all these things are probably different flavors of granuloma annulare, okay? So my understanding is that if it's on sun-damaged skin with actual solar elastosis, and you see the GA type look with elastophagocytosis, then you would call it actinic granuloma. If you have a GA with elastophagocytosis on non-sun damaged skin, then you would call it annular elastolytic granuloma. I don't get too hung up on this. I've called plenty of things just granuloma annulare where I've seen elastophagocytosis. So I kind of think that some of this is just GA where we're getting fancy because of the elastophagocytosis. There are times, though, I also do see this on sun-damaged skin as little foci of very subtle kind of interstitial granulomatous stuff with elastophagocytosis that I see in the background on like melanoma excisions, basal cell carcinoma excisions, where it's clinically not producing any lesion that's obvious. It's just little incidental foci of elastophagocytosis. So I don't know, what is that? Is that just incidental elastophagocytosis? Is it really subtle actinic granuloma? I'm not sure, but I see that often, like, I don't know, weekly maybe, like little foci of this pattern. So if it's being biopsied as the main lesion and they gave me this, I would say actinic granuloma or open parentheses granuloma annulare on sun-damaged skin, which is what I really think it probably is. Or if they wanted it to be annular elastolytic granuloma and it's not a sun-damaged site, okay, cool, we can call it that. But I really think that this is basically splitting and is mostly just academic. These are all just different flavors of a granuloma annulare-like process, in my opinion. So take that for what you will. Okay, case 26. Ah, fantastic example.
So here we have this like exophytic papillated don't-see plaque that has this amazing level of almost psoriasiform hyperplasia. However, you have these like pale bulbs at the end of dermal papillae, some of which come to tapered point. I would go to higher power, see what type of cells at the end of these tapered points. Already in my mind, I'm thinking something that looks a little warty.
Yep.
And when I get a little closer here, it looks as if there are some foamy, lipid-laden histiocytes.
Good. Yes.
And so I would verruciform xanthoma.
Very good. Yeah, verruciform xanthoma. And really, with practice, the low power appearance is pretty distinct for these. It's papillomatous, verrucous, warty-looking surface with a bright pink keratin, usually without a granular, usually with a lot of neutrophils. One of my friends taught me it looks like a wart on fire. And I thought that was a pretty cool way to say it, that it's warty and then it's like bright red flames of keratin on the top. I liked your point, pointing out that it has some overlap with the pattern of psoriasis a little bit, right? Because of the loss of the granular, the parakeratosis, the neutrophils, the long reedy. So it does have this kind of overlapping psoriasiform sort of feel, but is way more papillomatous. And then when you go closer, the classic finding is that you'll see foamy histiocytes in the dermal papillae. So it's really, I used to say nothing else really looks like this, but I have one time seen a case of actual verrucous carcinoma, because verrucous carcinoma can have some similarities in the corneal pattern. I did see a case that was a superficial biopsy that I thought was going to be verruciform xanthoma, and then when they excised the whole lesion, it turned out it was actually verrucous carcinoma. So I would not have, I have no concern at all about verrucous carcinoma, but in that one case on a partial biopsy, it did trick me and made me think of verruciform xanthoma, and only with the clinical being that it was so much larger and then them needing to excise it, then we were able to see that, oh, actually, it was actually verrucous carcinoma in that case. But here, this is a classic verruciform xanthoma, and these are not associated with any lipid abnormalities. The thought is that this is kind of a degenerative type of foamy histiocyte accumulation. They can occur in like oral mucosa, which I think is where this case might be coming from. and also in the anogenital skin. And I've rarely seen them like on the extremity or other sites, but usually either oral mucosa or anogenital skin is the most common sites to see them.
So this one we can see is a big process.
Yeah.
Filling up the entire biopsy, top to bottom, side to side. And we can see from here, it's just like a dense infiltrate of something at this point. And as we go in, we can see all these cholesterol clips over there.
Yeah, very good.
And then kind of some foamy-ish looking histiocytes, clear to foamy.
Yeah, definitely foamy.
And then there's like all this like strands of collagen throughout. That makes me think of tuberous xanthoma, and then the like onion skinning look also I feel like is helpful.
Yeah, very good. Excellent. Yeah, this is something I rarely have seen these in practice. I don't know if they really are rare or if they're just recognized clinically and not removed. I'm not sure. But I can't remember if I've ever actually diagnosed one in practice. So it's something that I just really do not encounter. But they are large nodules, kind of sessile to polypoid nodules, often on the knees, the elbows, or the buttocks. And they are a type of, so a large kind of, a large xanthoma. And they are often, they're usually associated with familial dysbeta-lipoproteinemia type 3. I have to look that up every time. I can never keep it in my brain. And there are a few other systemic lipid abnormality syndromes that they go with. But the classic, most common one is familial dysbeta-lipoproteinemia type 3. And these patients have a risk of peripheral vascular disease as well as, cardiac and other disease because of their lipid abnormalities. So it's important if if a patient gets diagnosed with one of these, they definitely need to have their lipids checked. And early on, they just start out with xanthoma cells, kind of like a xanthelasma would. But as they continue to grow and get larger and get older, they begin to get the accumulation of cholesterol clefts, which we see beautifully here. And they also begin to get more and more fibrosis and sclerosis. So and that's what's giving it that kind of onion skinning layered appearance, because at first glance you might think, oh, this is just the normal reticular dermal collagen, but it's not. It's too thick and it's too like skinny and dense and wiry. And the way it's packed together tells you that it's actually forming here around the foamy histiocytes. It's actually not like normal dermal collagen. It's really sclerosed and wiry collagen. Now, how do I know these are cholesterol crystals? Well, I think cholesterol crystals and keratin granulomas can look really similar because here the little layers of either collagen or histiocyte cytoplasm can look similar to the little flakes of keratin inside something. So I actually really struggle sometimes to tell them apart. I do feel like cholesterol crystals tend to be like kind of longer and more like parallel typically, whereas keratin granulomas tend to be a little more haphazard. But honestly, I have been tricked before. And so if you really need to, you can actually do a keratin stain, which will stain even the dead keratin flakes, but will not stain cholesterol crystals. So just so you know that if you struggle with telling those apart, I do too. In the skin, when we see clefts like this, usually the answer is keratin granuloma. Much more often, that's what we see. But occasionally, there are settings where we can see cholesterol crystals. And this is an example of that. So a really good example of a tuberous xanthoma. And I think there's some overlap with these and tendinous xanthomas, which I've also never seen. I think those rarely get excised because they are actually filling up the tendon and it would require excision of a part of the tendon. So I think generally those are left alone unless they're causing significant problems, although I'm not an expert at that. And like I said, I've never seen one. So if you're out there and you know more about that, maybe you can fill us in the comments down below. But I feel like those often get taught kind of alongside this, but those are going to be down deep in the tendon itself or are directly affixed to the tendon, whereas a tuberous xanthoma is a dermal and or can also involve the subcutis, I believe. So I think a faded example, but a really nice example with all the textbook features. Okay, 28.
For this one, I'm struck by the anatomic site clue.
Good.
It looks like the epidermis is a little pale, and the corneal layer, the granular layer, strikes me like this might come from lip or mucosa, oral mucosa.
Good.
And supporting that are these almost like cauliflower-like structures at the base of the specimen with cleared out areas that I think are good for salivary gland.
Very good. Yes.
And then the histologic process is this sort of cystic area filled with amorphous material and inflammatory infiltrate. With all of those said, I think that this could be a mucocele that is kind of ruptured and causing a lot of secondary inflammation.
Excellent. Yeah, this is about the best example you could hope for of a mucocele. And like you said, the first thing is recognizing the site. We've got mucosa, right? Because like you said, there's no granular layer and minimal keratin on the top, no skin adnexal structures. So this is from a squamous mucosa site. And then down here, if we're lucky, we will actually see minor salivary glands, which are mucinous type of glands, and then the ducts, which are lined by double layer columnar type epithelium. So those are minor salivary glands, which are on the mucosal surface of the lip and cheek. And then what has happened is that one of the salivary gland ducts has gotten blocked and then ruptured. And as it ruptured, it spilled out the mucus secretion, and that has made a pseudocyst. So if we look here, what we would think was a cyst lining is actually not epithelial lining at all. It's lined by a layer of kind of palisaded, frothy, foamy, mucin-filled histiocytes. And then you also have mucin-filled histiocytes, or muciphages, if you will. But they look like they're lipid-filled, but they are probably mostly filled with mucin material. But they look very similar to xanthoma cells to me, maybe a little bit more blue. And they're free-floating in the middle here. So it's basically a pseudocystic type reaction to the spilled out mucin secretion from a ruptured salivary gland or salivary duct. So even if we just had this top part up here on the lip, and I see some foamy cells around a central cystic area, plus minus some free-floating ones or some mucin, I would say it's suggestive of a mucocele, even without all the deep stuff. But how much better when you can get all of this? So a really, really good example of that, of a mucocele. Or the other name that's been given this is mucus extravasation phenomenon. Okay, 29. This is another one where the anatomic site is really important. So I'll give you the clue for that here. What are we dealing with here?
Well, I see this delicate skin filled with these goblet cells.
Good.
Which makes me think that this could be coming from the eye.
Yeah, good. This conjunctiva, right? It looks like really thin epidermis until we realize there's no stratum granulosum, there's no stratum corneum, so it's actually mucosa instead of actual skin or epidermis. And then there are goblet cells. Sometimes they're abundant like this, sometimes they're more rare. It kind of depends exactly on where exactly you're getting the sample from. But thin stratified squamous mucosa with goblet cells is conjunctiva. Good. And then down in the subconjunctival, submucosa, I don't know what you call this. I get used to saying epidermis and dermis because that's what I look at all day long, but I guess technically this is subconjunctival submucosa rather than dermis. But in any case, down in here, there's a ton of inflammation. So what is going on, do you think?
So I feel like the clinician was worried about this maybe irritated red spot, and they were thinking, gosh, could this be skin cancer or inflammation that can cause a granulomatous process near the eye, which is called chalazion.
Yeah. So what? Much of this is kind of non-specific. Like it's a bunch of lymphocytes, histiocytes. The classic finding that we want to see is actually like a lipogranuloma. So here we're getting some foamy histiocytes. So that's telling us there's probably some lipid around here. And down here we're actually getting some granuloma with kind of an open, vaguely cleft-like space, so probably there was some lipid material in here that washed out during processing. So you can have variable amounts of lipid mixed with the granuloma. So lipogranuloma type pattern with brisk inflammation along the margin of the lid of the eye, it is good for chalazion. Sometimes you can see fragments of the meibomian gland, which is basically a large modified sebaceous gland. that's on the eyelid, and the function of those is to produce a sebaceous-like secretion that's oily. And I learned this from a colleague, which I thought this was really cool, that the idea is that because it's oily, that secretion is, the point of the secretion is to float on top of the aqueous liquid on the surface of the cornea and to prevent it from evaporating. Now, I don't know if that's true, but that's what I was told to me by someone much smarter than me, and I thought that was really cool, that's why it's like lipid-based secretion that is supposed to cover over and try to help avoid evaporation of the aqueous portion of the tears, so that it keeps the surface of the eye moist. And I thought that was quite cool, because otherwise I was like, why are meibomian glands there? What do they do? Well, I guess that's what they do. But when they rupture, they produce a really brisk inflammatory response, and that's a chalazion. And like you said, red inflamed papular nodule in the eyelid could also be skin cancer, either sebaceous carcinoma, squamous cell carcinoma, basal cell carcinoma. So it is important that they wanted to make sure that's not, that there was not a malignancy here. But sometimes you can see the fragments of a sebaceous gland in that. And so when that happens, there are times where I've not personally encountered a case, but I've heard from one of my ophthalmic pathology colleagues that when there are entrapped sebaceous elements in there, sometimes you can get, people can get that confused with actually sebaceous carcinoma. So make sure to not do that, because you may have some reactive atypia and then some actual sebacites. So you want to make sure to not confuse sebaceous carcinoma and chalazion. All right. And I think what is the other? Oh yeah, and you don't want to confuse this with a sty, which is like basically a kind of a ruptured folliculitis type process that's actually in the hair follicles on the margin of the lid. So chalazion's a little different. It's from a rupture of the meibomian gland.
Yeah, so this is a challenging one.
Yes.
But dense inflammation throughout here. Oh, okay. And yeah, we'll just have to see what's in these areas.
Yeah. One thing, when you see like big fragments of tissue that are really ragged on the edges, lobulated fat and dense fibrous tissue, and it's kind of jagged edges and there's no epidermis, that always is a clue for me that this might be soft tissue from the hand or foot, or right about there, because I think it's partially due to the anatomic site, but also partially due to the way that hand and foot surgeons gently dissect and blunt dissect, because of all the vital, important structures in the hands and feet, that they're kind of pulling out the tissue and it tends to kind of rip away and leave these jagged edges. And I think that I don't know why, but hand and foot fibroadipose tissue has a look that's kind of different than other sites. And I think it's because of all of the tendon sheath and also because of the way the surgery is done, that it often gives it this jagged, ragged look. So that's kind of a clue. If you see a chunk of tissue like this on a test, start thinking, wonder if it's in the hands or the foot. This is from the hand, actually, per my my answer sheet. So yeah, then we'll go closer and see what's all the stuff in here. So here's one representative example. So what are we dealing with here? What kind of process do we have? Oh, I think maybe you're muted.
Sorry about that. Yeah, I got it. Thanks. Sorry about that.
No problem.
And so yeah, we have a palisade arrangement of histiocytes around neutrophils.
Yeah.
So palisaded neutrophilic granulomatous dermatitis.
Yeah, so exactly. We've got a granuloma with neutrophils. So some people will call this like suppurative granuloma, or suppurative granulomatous change, or sometimes if they get more spiky, people will use the term like stellate granuloma. This pattern right here is infection, 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 infection until you prove it's not. And even then, still might be infection. So all joking aside, this pattern is, to me, infection until proven otherwise. Aggregates of neutrophils in the middle of a granuloma, plus minus necrosis, that's usually an infectious process. And remember, the hands and feet are places where we get penetrating injury. You stab your hand in the garden, and so you can get some deep fungus or some AFB or something that gets down in there. And also, it's an area where we don't want to miss infection, because if the infection gets down into a joint space, you might be talking about septic arthritis, osteomyelitis, partial amputations, serious complications. So we always want to make sure we are very vigilant to look for infection at these sites. So this looks so good for infection, and some poor pathologist did infectious stains, and they were all negative, despite how much this looks like it should be loaded with organisms, negative. But then cultures were done, and it grew out Mycobacterium chelonia. So this pattern is not totally specific for that species, but this pattern right here, I would say deep fungus and Mycobacteria infection are the most common types of infectious process you're going to see. But if you find this pattern of granuloma, that's infection until you prove it's not. So you try the stains. If the stains are negative, you can also send it out for molecular testing for PCR, which can help identify organisms. Although in cases where organisms are really rare, like the cases with stains that are negative, a lot of times the molecular will come back negative, and it's always a possibility of a false negative, because when you have very few organisms, there's very little nucleic acid from the organisms to amplify. So if it's positive, very helpful. If negative, still doesn't fully exclude infection. So usually what I do in a case like this, if I'm highly suspicious for infection, but I don't see any organisms, I sign it out as, suppurative granulomas. This, even though I didn't see organisms, it's highly suspicious for infection. And then I say I'm going to send the tissue for PCR testing. And in the meantime, I recommend that they repeat biopsy and get culture started, because some of these organisms can take a while to grow. So usually I want to use all the different approaches. Maybe you could argue that's overkill, but I would rather do that so we get the diagnosis as soon as possible. Even if it is a little bit more expensive to do it that way, I feel like in the long run, it's not that much more expense to make sure that we're getting an infection caught as early as possible so they can start treatment. Okay? So this ended up being Mycobacterium chelonia. Well, we're nothing up there, then way, way, way down here, there's something.
We have this sort of palisaded granulomatous dermatitis look.
Mm-hmm. I like that you added the word look. Good.
However, in the middle, I note that this amorphous material is somewhat pale. It doesn't really look mucinous. It doesn't really look darker like I would think with fibrin. So I am sort of cluing into the entity that I never want to miss. I've never seen it before, but I'm always afraid of missing, because at the periphery of this amorphous area, we've got kind of these large epithelioid cells that look a little bit atypical, large nuclei, some hyperchromasia. It's very deep. On my mind is a differential that maybe included other entities like deep GA.
Absolutely.
Or rheumatoid nodule, but it's not typical for that. It's got these other mixed features, so I'm worried about whether this would be an epithelioid sarcoma. And I did a little reading, and in terms of staining, if I wanted to work this up, I read that loss of INI1 is seen in over 90% of these entities, so I would use that for confirmation.
Very good. Yeah, so in the old days, back when there were very few stains, people would say this is positive for keratin and vimentin. And you guys all know how much I hate vimentin. But in the old days, it was fine because there was not much else. So, carcinomas are often keratin positive and vimentin negative. Although when carcinomas get spindly and look like sarcomas, they tend to start picking up vimentin. So in any case, I don't think there's any need to use vimentin for anything in bone and soft tissue pathology in modern times. But in the old days, that was the classic finding. And then people also described that CD34 is positive in the majority of cases, which is something that carcinomas are usually not positive for, right? But we know that CD34 is also a pretty non-specific marker. It can stain a lot of stuff. So thankfully now we have a better marker, and that's INI1, or also known as SMARCB1. And what you'll see is it's a stain that is lost. Normal nucleated cells should express it. This tumor and a growing list of other tumors unrelated to this have loss of INI1. So, and there are other members of the SMARC family, like SMARCA2 and SMARCA4. Other types of malignancies can have loss of those markers. So this kind of whole family of proteins that can get inactivated and lost and then drive tumor growth. And so you can read more about that. That's a long, complicated discussion. But in this setting, I do not like to use INI1 as my main screening stain, mainly because technically I find that it's kind of hard to work. It sometimes has weak internal control. I'm actually currently working on trying to improve a validation of that to try to get a better staining, because it's something that I've always found is kind of a struggle to get it to work really well and crisp staining. And when I'm using a screening stain, I want a crisp, strong stain that works very, very reliably, right? So I like to use, if I look at something and I think it's maybe deep GA or rheumatoid nodule, but then I look closer and I see the cells are a lot bigger, a lot more atypical. They tend to have, some of the cells are a little dark, but some are very pale, white, kind of vesicular chromatin. That's a really typical cytomorphology for epithelioid sarcoma. So these, I think, are much more atypical and large than GA or rheumatoid nodule. But what about these up here? I mean, these are subtle. Those cells look relatively bland and not very atypical to my eye. So if you have any doubt, just do the stains. It's real easy to make this distinction. Okay, I mean to do stains to help you here, because I do feel like there are cases that even as a soft tissue pathologist on some areas I'm like, boy, that doesn't look very atypical. Look at that. And the cells are a little bigger, but I mean it can be subtle. So in any case, I like to use pancytokeratin and an EMA as my go-to. I used to just use keratin, but I did see a single case once of epithelioid sarcoma that was basically completely negative for keratin on the biopsy, and it was EMA positive. And on the full excision, there was some focal keratin, but basically it was mostly keratin negative, which is terrifying. But it was diffusely EMA positive, and it had loss of ion I1. So the center sometimes, I mean, look, there is kind of degenerated collagen and fibrin in here. There's also some mucin up here. So it could mimic GA or rheumatoid nodule because of that, but classically the center will also have necrotic tumor cells. So that's something we don't really see a lot of dying actual ghosted out tumor cells in rheumatoid nodule or GA because they're not tumors, they're histiocytic processes. But I feel like these, sometimes epithelioid sarcoma is very straightforward and obviously atypical. I have seen some terrifyingly subtle cases though. So my general rule is if I look and I can't decide, or if I have any doubt, I just add those stains on to sleep well at night, okay? Because, and usually when I've done those stains and it was just a rheumatoid nodule or GA, it's negative, you know? Like most of the time, if I have to think about it though, I'm like, maybe I should just do the stain. All right, so you know, it's an important thing to keep in mind because if it's not on your radar, it's really easy to miss this. If you don't know that there's a sarcoma that's really rare that can grow like a rheumatoid nodule, then it's easy to look at this and say, oh, rheumatoid nodule, right? And they're clinically often in the extremities of young adults or kids sometimes, unfortunately. These tend to occur in younger people, although I've also seen a case in the finger of a 90-year-old patient before. So I've seen a wide range of ages and presentations. So just so you know, that's possible. All right. So the presence of atypia is the really important key. But oh yes, they usually occur in young adults or sometimes kids, and also they tend to be a kind of non-specific nodule on the distal extremity, hands or feet, you know, wrist, ankle, that kind of area. And then they sometimes will ulcerate. So sometimes they'll present as like an ulcer that keeps recurring and doesn't heal. I've seen cases where they've, you know, done I&D, incision and drainage. They've tried to debride it. Then someone finally is like, you know, a year later, like maybe we should send some of this for pathology. And it turns out the whole time it was epithelioid sarcoma. So it's a terrifying case because it clinically presents in the kind of person that you would not expect to have a cancer. It doesn't look like a typical skin cancer or a typical soft tissue sarcoma in the way that it presents clinically. Microscopically, it sometimes looks very bland and has a growth pattern that can look like rheumatoid nodule or GA. So for many reasons, it's a very scary tumor, and it's very, very rare. I only probably see it maybe once a year, sometimes even less than that. So it's quite uncommon, thankfully, because it's a terrible tumor that often has a tendency, even with complete excision, it has a tendency to recur and have kind of satellite-type lesions and in-transit metastases. Even after you excise it, tends to grow back and have satellites, and then it can metastasize to regional lymph nodes. And the last time I read about it, the prognosis is about 50% of patients eventually die from disease. And I think that does depend on how long you follow the patient. Sometimes patients can have a protracted clinical course where the tumor kind of has a relentless recurrence. So it's horrible because it has such an insidious and persistent kind of growth pattern, and because it's an easy thing to overlook and miss. So I like to harp on this entity because of all those reasons. It's a terrible pitfall. And in this case, you can tell this is an excision. This patient had had a biopsy before because look over here, we've got some suture granuloma and scar. So this was part of a complete excision or maybe an amputation specimen for this tumor. So epithelioid sarcoma. All right, guys, as usual, we went way over time, but thank you for those of you who were able to stick around. And to everyone watching online, thanks for watching. Hope you learned something and hope you enjoyed. Have a great day.
Thanks, Dr. Gardner.
You're welcome.